His radio wise.
Oh gosh, I can see all the important people.
She actually, she
Either one could. Yeah.
but she'll walk
I'm sure they are.
Do we have a
So is this your meeting? Do you have all these meetings?
I will be at all of these meetings. I was even dodging the back for the next testimony.
Well, it's so funny. Here's what I said today. I said, she won't be late, but she'll come in 2 minutes before the time. I said, why don't you just text her? I said, no, I knew you would be late.
Yep.
You're not late. You cut it a little close. You got to admit it. You cut it a little close.
I wake up.
I get it. Well, the other thing is these things never start on time.
Maybe.
Except unless I run into Sorry.
No, you I sent the text and you would be there.
Of course. So it was right. I'm never late, but I also don't believe in you know. Come in 5 minutes. Right. No, 5 minutes beforehand, I guess.
Dana Harganani. I think we've met before in the opioid epidemic. Oh, that's right. I was trying to be fair.
Yeah, what? I can't hear you.
Okay, you know, like the whole, like in kindergarten.
Yeah, I got him. I'll get him.
I need to ask them all
Oh.
parking. Like,
So folks, can I get your attention for a moment? We're gonna get started in just a minute. So we're gonna get started in a minute, but before we do that, Lisa Bowie has an important announcement or question.
I have an important question.
Okay.
I need you all to raise your hand if you parked in Liberty Center. And just keep it raised, please.
You have 2 people over there
We
too,
need your
so
orange
who just
sticker.
walked in.
For your orange ticket.
You want the you want my ticket? You want my ticket?
Yeah.
How do you know it's my ticket?
You're okay. I got you.
Come join us at the table.
See if there's, you have your sticker, you have your sticker.
Do we put our names on it so you can get back? Or are you just gonna?
I just need to put stickers on your car.
I see. Sticker me.
And I don't think your particular
Okay.
ticket.
No one else parked in
You just
Liberty
need a
Center?
ticket. It's not linked to your car.
Well, you can go in and out at different times.
And you all are all ready to go. I love it.
Or does it always?
Okay, and one more. You said
Doesn't
coming?
matter.
Yeah.
Doesn't
Thank you for
matter.
indulging. We'll get you your stickers.
It's good for the rest of my life.
No, perhaps you only have a comment in person unless somebody
I'll bring it
has
back.
requested special accommodation.
So it's in.
That's exactly as it should be. And if for some reason I need to go get some of the materials over there.
Oh.
We're accepting public comment or public comment. Or if they've asked for special accommodation, we can do it differently. But so if anybody emails or joins us or asks you, you can let them know.
And then you guys just unmute it whenever you're ready.
Go ahead.
Yep. So we're gonna get started.
We're unmuted.
We're unmuted. Hi, folks on the phone. We're gonna get started, everybody. I'm Diana Bianco with Artemis Consulting, and I'm going to be facilitating this process with all of you over the next number of months. And I'm going to, in a few minutes, share with you a little bit about the agenda and our goals for today and some other logistical details. But before I do that, I'm going to turn it over to Dana Harganani and Katrina Hedberg, and they're going to do a little bit of a welcome, and then we're going to have an opportunity to go around the room and check on the phone as well and do introductions.
Want me to start? Great. Good afternoon, everybody. You have received some communications from me. To date, my name is Dana Harganani. I'm the Chief Medical Officer for the Oregon Health Authority and have been in this role for just over a year. Came on board when some past work was just kind of in the middle of the way, but generally speaking, relatively new to the work that you are all embarking on. So I greatly appreciate your interest in applying and now your commitment to serve on this task force. Katrina, why don't you go ahead and introduce
Sure.
yourself?
So I'm Katrina Hedberg. I'm the state health officer and state epidemiologist. And I'm like Dana. I've been around here almost 29 years, so a long time. And I know many of you. Some are new faces, but I've been very involved. I'll talk a little bit more about. But with the previous guidelines that we have put into place for acute prescribing and for chronic prescribing as well. So I'll talk a little bit more about how these fit into that. But again, we've been involved with this work for a long time, and this is a continuation of what we've been working on.
And before I just pass it back to Diana for walking us through the agenda and our plan, I just wanted to make it really clear from the outset kind of what the purpose is that we're all coming together. We're going to dive into this in further detail throughout this meeting, of course, but really the outcome that we expect and hope for this task force is that come fall, we will have a set of task force guidance around opioid tapering that really promotes compassionate, evidence-based, expert-informed guidelines around opioid tapering. We expect and hope that the guidelines produced by this task force will really serve as a very useful framework moving forward for patients, providers, all in our state to ensure that we have trusting dialogue between patients and providers, competent, compassionate, and safe care. So really that is what we are ultimately striving for. And this is a really important kickoff meeting to kind of getting us together, understanding who we're all at the table and how we're going to move forward in this work.
Good. Thank you so much, Dana. I want to go over the agenda, and then we'll go around and do introductions. So really, as Dana said, today is some context setting, but we're going to dive right into the work as well. You'll hear, first of all, I want y'all to have a chance to know who else is around the table. So we'll have a couple of questions that I'm going to ask everybody to answer. We'll take some time to do that. And then, as Katrina alluded to, she's going to give us a little bit of background, sort of the scope of what we're talking about, what's happened, what's come before us, and the need and why we need to do this work. Then we're actually going to hear from all of you, and that's really going to be the rest of our meeting. We want to talk about principles for the guidelines. What should we be considering? What should be sort of foremost in our minds as we craft the guidelines? And then we'll start talking about sort of what has to be included in those guidelines. What are the key components? And again, we'll want to hear from you. We'll also be talking a little bit about the resources that are available and make sure that we elicit from all of you if there are additional resources we should be paying attention to. We're also, because these are public meetings, we're going to have public comment at the end of our meeting. If anybody in the audience wants to provide public comment, we do have sign-in. Please make sure you sign in. The other thing I want to check before we get going is whether we have any task force members on the phone. So are there any task force members on the phone? Ash, do you think we...
There's 5 participants calling in.
There's 5 task force members who have called in. Okay, so do they have a number that is not muted? So we have to make sure that they can participate.
Oh, okay. So then you just take it out of listening mode.
Okay. Okay, so can you do that for us? Okay, so we will. So folks on the phone, task force members on the phone. So here's what I'm going to ask. If you are a task force member on the phone, we encourage your participation. We'll make sure you get introduced. If you are a member of the public on the phone, I'm going to ask folks to not chime in. That's a listen-only opportunity. We're taking public comment today in person, in writing, or if you've requested special accommodation and need to provide testimony on the phone. Ash says we haven't had anybody who's done that. That's got to happen a little bit in advance so we can prepare for that. But folks on the phone, and see, I'm looking at the phone like it's a person. So I want them to know I'm paying attention to them. I would just want to make sure that task force members on the phone, I want to be sure you have the opportunity to participate. To that end, these are all these fun logistical things we get to talk about, right? We have microphones here. Task force members on the phone, if you can't hear us, we want to be sure we know about that. So please chime in.
To place, all participants are now in interactive talk mode.
Great.
And I will.
See, it is talking to us like it's a person. All right.
Would you like me to mute them and they have to unmute themselves, or just leave it?
Why don't you can just leave it. It's okay. And if we need you to do that, we'll do that. Thank you so much, Ash. Okay, so we are now going to get started. And just so you all know, I've worked with some of you, but not all of you. I'm a health policy consultant. This is what I do for a living, is work in health and healthcare, because I care a lot about Oregonians and their health and well-being. And my role is to help you all have a good conversation, right? So that you can fully participate, so that I want to be sure everybody's has an opportunity to be heard, that we have discussion that moves us forward. And at the end of the day, this isn't my meeting, it's your meeting. So if I'm going too fast, if we're going too slow, unlikely, because I'm from New York originally, but this is your meeting. You tell us if you need to stay somewhere on a topic, please let us know that. This is to hear from all of you, okay? And my role is to keep things going, but also to summarize, also to make sure that we're hearing from all of you. Right?
Can I add one thing?
Absolutely, Katrina.
So similar to the other work that we've done, and I'll get more detail about this, I want to be clear from the get-go, these are not OHA guidelines, these aren't state guidelines, et cetera. We're serving a convening function around this. There's many of you in the room who've actually come up with tools. I'm looking at Jim Shames around some of the work, tapering. So we're really looking to all of you, both for subject matter expertise, but also to come up with something that would be, if you will, a document around what could be served as state guidelines, so that it really is kind of a standard of practice in the state of Oregon. So I just want to be clear that from our perspective, you all are experts, and we're really in a convening function. And this has come up with the other guidelines too. People often say, why is state government? We say, well, actually we're convening. These aren't for the state of Oregon. They're not the state with a capital S. They're really to have a standard of care throughout the state. So hopefully you all will see that and call us on it if you feel otherwise. But you all are the experts in this area.
Thank you so much. Okay, so now we're going to do... Oh,
sorry.
Yes.
Sorry, this is Roger.
Hi,
Chow.
Roger.
Can I ask a question, Katrina?
Absolutely.
So I think many are aware that OHA has been working on some policies around tapering, and just trying to understand how what we do fits with that, and what happens if what we say is contradictory or whatever with the OHA stuff.
Yeah,
Hi, Roger. This is Dana Harganani. Thanks for bringing that question up. I'm going to speak to it in just a few minutes after we do introductions. So if you're okay holding that, and if I don't adequately answer it, please let me know.
Okay, that's fine. Thank you.
Thanks. All right, so here's what we're going to do, and the questions are on your agenda. So there's two questions, and I'm going to ask folks to answer them briefly. And I'm actually going to give you a minute to write them down so that you can actually listen to what other people are saying. So two questions. What perspective do you hope to, so your name, either the organization you're representing or the sector, if that makes sense. And then what perspective do you hope to bring to the task force? And then from your perspective, how would a successful outcome from the task force help our state? What difference would it make? So take a minute or so, jot it down, and everybody will have about a little less than a minute to answer, just because we have so many of you, but we really want to hear the perspective, and from where you're coming from, how would a successful outcome from the task force help our state? And folks on the phone, I will make sure the task force members have an opportunity to introduce themselves as well. Bless you. All right, so just take a minute and, not a minute, 30 seconds and wrap it up. All right. All right. We're going to start right over here.
Okay.
And please do, so especially if a mic isn't close to you, make sure you're speaking up.
Should I look at that too?
Please.
My name is Joe Schnabel. I'm the Executive Director of the Board of Pharmacy, but until last month, I was the Director of Pharmacy at Salem Hospital. I also teach pharmacy law at Oregon State University College of Pharmacy, and I have to leave at 2 o'clock today to go talk to the pharmacy students for the last time this term, so you'll excuse me, hopefully, if I sneak away. The perspective that I hope to bring is that of a hospital pharmacist, because I still have some fresh experience in the hospital setting, and also the regulatory perspective from the Board of Pharmacy. And I commit to the collaboration of the board with this group and with the OHA on this project. Also, pharmacists like to educate patients, so the other perspective is how pharmacists can help educate patients on the opioid tapering process, opioid treatment in general, and just how understanding how opioids work and the kinds of things to expect from therapy with opioids.
Thank you so much.
Hi, I'm Steve Harris. I might be the only therapist here. I'm dual diagnosis. I work at a residential treatment program. It's a mommy and me program. I also work at an intensive outpatient for mommy and me and daddy and me. And out of that, I get the opportunity many times to see the patients that you're working with for 40 hours a week. And so my perspective is relaying the behavioral information back to the ones that are prescribing. That gives me the opportunity to actually see clients from induction to taper and actually after taper. That gives me quite a privilege of working with all of your patients. My hope for the outcome is based on effectiveness of the mats that a certain individual might be using, is how that tapering would work depending on if it really is effective or if it is difficult for them to manage them from a behavioral perspective.
Thank you so much.
My name is Eve Klein. I'm the medical director of CODA, which is a substance use treatment program. Actually, it's an organization with 12 programs. The majority of our patients do have opioid use disorders, although we serve other substance use disorders as well. And also my background is that a few years back, prior to this, I used to practice pain management. So I'm coming from the perspective of, in the process of tapering opioids, sometimes opioid use disorders are uncovered, and I want to make sure that treatment for use disorders is as connected, accessible, and part of that package as possible, so we know how to screen for it, what are the warning signs, and how to route patients to services when those signs appear.
Thank you.
Yep.
I'm Lisa Whitmore. I'm a nurse practitioner. I work up at OHSU on the inpatient side in our pain management team. I'm hoping to bring some inpatient perspective. A lot of our patients start opioids with us post-trauma or post-op in the hospital. And I'm hoping a successful outcome would look like a patient-centered approach and a nice collaboration from all of us to kind of set clear expectations for patients.
Thank you.
That's Helen.
It's
patient care. I just had her. My name is Kim Maurer. I am the medical director of the OHSU pain program. We have both an inpatient and an outpatient program. And we do a lot of opiate prescribing and opiate tapering. And so I think my thoughts are similar to everyone's. My perspective I bring is just a lot of clinical care in a very big healthcare organization with a lot of teams that we collaborate with and a lot of different providers we interact with. And how do we best educate people when it is time to taper? We want to taper a compassionate way to do it, realizing that if we're going in the right direction, we're going in the right direction, and we probably don't have to maybe rush as much or find good ways of doing it and good education about it.
Thank you so much.
Hi, my name is Ruben Halperin. I'm a general internist on the faculty of Providence Portland residency. And I feel like I bring both a primary care and a medical education background to this. Primary care, whenever the words opioid or taping or use disorder are used anywhere near each other in a paragraph, causes all kind of anxiety and palpitations and stress ulcers and stuff like that. And I think with any kind of opioid tapering guidelines, primary care physicians feel like the bulk of it's going to fall on them. And you know, we generally have not been trained to like identify opioid use disorders or treat them, and now there's a big push to treat them too. So I hope to have input as to make this palatable to people who are going to be on the front lines and doable. And if it's successful, I think we'll have clear guidelines to help physicians work with patients so that we're not doing either black and white kind of, okay, you're off opioids now, to the wind kind of thing. And I think I'm on the Oregon Pain Management Commission. We've seen a lot of that, after CDC guidelines came in, we got a lot of calls, people complaining that their doctors are saying, no, my organization says I have to take you off opioids. So if there's a way to smooth the landing, then I think we will be successful.
Yep. Thank you so much.
So good afternoon, I'm Sue Stewart. I am a citizen of the Calgary and Quatrapan Indians, which is one of the 9 tribes here in Oregon. I actually spent the last 18 years as a primary care provider in Alaska and treating in small villages, and we end up doing a lot of care up there looks very different than it does down here. So, but we do take a patient-centered approach. We do what's best for the patient. I am hopeful that we have, as has already been said, gentle guidelines, understanding that not all fixes are the same for every person, that we look at a number of modalities for the tapering, and I do hope that we can include the tribal-based practices in our final guidelines.
Great.
Thank you so much.
Thank you so much.
Hi, I'm Ariana Schott. I'm a recent transplant to the Portland area from Northern California. I'm boarded in emergency medicine, hospice, and palliative, pain eligible, but refuse to take any more board exams.
We're cracking.
2 out of 4 is enough for paperwork. I created Kaiser's only inpatient integrative symptoms management service in Northern California that was attempting to address a lot of what we are attempting to address here, which is how do you deal with opiates, when is it appropriate, when to take them off, and how do you deal with patients who fall on the outer sides of the bell curve. And originally we started as the voodoo and witchcraft service, and by the time I left 7 years later, we were kind of Dr. House, and where they said to everyone what to do with. So that's kind of the perspective I'm coming from to this. Here in Portland, I am the pain lead for Legacy Health Systems, we're a 7-hospital system, in creating their new pain protocols across the 7 hospitals to really address how do we taper patients safely and effectively, and really providing an enormous amount of education surrounding what adjunctive measures are available. To echo some of Ruben's comments, I think one of my biggest frustrations, especially with my palliative care patients, I've had 2 patients referred to me for death with dignity because they were taken off of opiates and their pain was so severe that they were referred to the palliative care team to help them die, which raises enormous alarm in me. Both of those patients, thankfully, are doing fine now and did not go the death with dignity route once their pain was appropriately managed. But I'm very concerned that the messaging that is going out to physicians at large is opiates are bad, no one should ever have them, we're just going to take patients off. And I'm hopeful that my presence here and our joint efforts will really address the fact that you cannot just take opiates away without offering a safe platform for substitution that does not involve heroin, that does not involve wanting to come to me for death with dignity. And there's an enormous amount of education surrounding that I think we need to do.
Thank you so much.
I'm Minnie Dogra. I am a pain physician, anesthesiologist at the VA Portland Healthcare System. So I bring a unique perspective here because we kind of live in a bubble, even though we do train our pain therapists. We have a lot of data at our disposal, and with the Choice Act, we're sending a lot of our patients out to the community. We have a lot of guidance guidelines that we have to follow, and yes, they're guidelines, but they end up being diktats, right? So we actually got funding to bolster my clinic, so I'm only doing 100% pain now, and I'm also representing our institution, the National Pain Committees, as well as the business level. So we're trying to come up with guidelines for tapering. In my clinic, actually, we will take over the highest opioid dose patients, and we have a psychosocial team. We're getting an acupuncturist, chiropractor. So we're trying to provide the adjuncts. We have been participating in the opioid safety initiative since 2011. That's when I started the VA system. Now that with the Choice Act, now that since we're sending out patients to the community, I want to know what the guidance is going to be from this group, which kind of aligns with what the VA wants to do. So it's not that when we're sending patients out, they're coming with something that we're not aligned with. We are actually making anybody who is on more than 50 NEDs to put forward a current authorization drug request. So we want people to actually pay attention to their patients to see, is it for chronic pain or is it for palliative care? So we're not just blindly tapering people off. So I think it'll be good for me to know what the guidelines is, to be involved in that, and to provide a compassionate and taper plan for patients that lines up with what we want to do and what we want to organize.
Thank you so much. Brandon, the perspective that you bring, please.
Yeah, so my name's BJ Lynch. I'm a medical director at Asante in Southern Oregon. So I, in this capacity, represent about 70 primary care providers who have come together to create our own chronic opioid prescribing guidelines and are also interested in tapering. And through that process, I echo what Ruben has said, that we've seen a lot of fear in our providers. So the thing that I think would be a success for this group would be if we came up with guidelines that were approachable by PCPs and patients alike, that they felt well supported in helping their patients through this.
That's great. Thank you so much. Mark.
Yeah, my name is Mark Cantor. I'm the pharmacy director for All Care Health. I'm here as CCO in Grants Pass in 3 counties in Southern Oregon. And so I come from a little bit of the payer perspective in terms of how we implement these guidelines that affect the CCO members and health plan members. When we went through the back pain guideline changes and then saw a wide variety of, in some cases, a lot of lack of communication between primary care physicians about what was involved and what was required, and then trying to facilitate those providers for our members.
Great. Thank you very much. Michelle.
Hello, my name is Michelle Maricos. I'm a peer support specialist for chronic pain. I'm a person living with chronic pain. I also have been through a high-dose opioid taper. So my perspective that I'm bringing is from a patient perspective. I also work with the Oregon Pain Guidance, so I work with a lot of doctors, and I am hoping that we really can disseminate some myths of what patients go through and what patients are feeling, really give that parallel process of what providers and patients go through a lot of thought, and that we can come to a different place than we've been previously.
That's great. Thank you for having me. Thank you so much. Laura.
I'm Laura Hisacker. I'm a licensed clinical social worker, and I work with Jackson Care Connect in Care Oregon as a behavioral health innovation specialist, primarily in the role as a practice facilitator, offering support and coaching and technical assistance around primary care behavioral health. And then I also am here representing Synergy Health Consulting, which is a fairly new consulting practice that supports primarily primary care, but other health systems around the state in the area of practice transformation in the realms of pain management and safe opioid prescribing, integrated behavioral health, and medication-assisted treatment. And so I echo what everyone said. I'm excited about all those things. I'm really excited about looking at our tapering guidelines to be able to lead to not so much of a black and white path, right? So maybe there's that place in the middle where we're looking at complex dependency that may or may not end up becoming an opioid use disorder, diagnosis, but that from spending years and years in primary care as a behavioral health clinician in primary care, and just watching the struggle around the stigma, primarily of opioid use disorder, as BJ likes to say, much more for the medical providers and the team than for the patients. But that's what and so I really hope that we land somewhere.
Thank you so much. Paul.
Paul Coelho, I'm certified pain and physical medicine and rehabilitation. I'm the medical director of the Salem Health Pain Clinic. We opened in 2016. We're essentially a deprescribing clinic, so we produce very high doses of opioids from 5,000 milligrams. And we deprescribe, so taper, and we transition folks to buprenorphine. And I'd just like to make a distinction, if it's possible for this group, between a taper and a wean.
Would you just speak up a little bit? I want to make folks make sure.
And this Roger hinted at that. I wanted to make a distinction between a taper and a wean off of opioids. You know, I think of tapering as tapering down to some other level, whereas a wean is a wean off. So I guess the perspective I bring is that of a deprescribing clinic. I do this work. My hopes for this are to reduce harms for patient and to reduce patient abandonment.
That's great. Thank you very much. Jim.
I'm Jim Shames. I'm the health officer for Jackson County. I do consulting work for Synergy. I work pretty closely with all the people on this half of the table. I did primary care for decades. I did treatment at a opiate use disorder clinic for decades, and primary, public health for decades as well. So my perspective is really those three areas.
A lot of decades.
You're not 100, Paul.
Some of them were overlapping, right?
Yeah.
And like county, I'm tired of recertifying all the boards. What I think is a successful outcome is for us to first and foremost be compassionate, flexible, and continue to look at the patient perspective, but recognize that as a healthcare provider, safety, the risk-benefit evaluation is really fundamental. And I think that if we keep coming back to that, and then learn how to approach people with compassion, have the difficult conversations, use buprenorphine when appropriate, not get frightened by opiate use disorder when we see it, I think we'll be successful.
Thank you very much. Kim.
Hi, I'm Kim Swanson. I am currently the Director of Behavioral Health for Mosaic Medical in Central Oregon, and I also am the Chair for our Regional Pain Standards Task Force. And I come at this through lots of lenses. I'm a former pain researcher from the University of Washington. I have 16 years working in integrated care settings as a psychologist, where you're naturally drawn to the work of opioids and chronic pain because it's so prevalent in those settings, and now as an administrator. So I have lots of hats and lenses that I look through. And I think through all of research and experience, the perspective that I bring is that this is such a great area of medicine, and that I would really like for us to have that balance of safety and compassion, which I just have to call out how super cool it is to hear that same statement echoed about across everybody across the room. So that's really lovely to hear that everyone really feels safe. That balance of safety and compassion is of utmost importance. If we're successful, then we're going to honor that this is not a black and white issue, that there are some middle grounds. It's not going to be all this or all that, and that we provide a structure in which respects clinical autonomy and makes our providers, especially primary care providers who are doing the bulk cut of this work, feel really like they have something that guides them and also respects their clinical decision making and independence in how they care for their patients. That's one. And two, I really feel that we have to increase equitable access to interdisciplinary care in our settings where the bulkhead of chronic pain is being managed, where we're supporting patients in a meaningful way. If we're tapering correctly and safely, and it's aligned with patient values, then we shouldn't see an increase in pain and distress, and they should feel really supported and heard through that process. And I think if we accomplish that, then we're right on pace.
Thank you very much, Kim. Go for it.
Katrina Buse, I'm also a pain psychologist. I am in the Comprehensive Pain Center at OHSU, been there 3 years, but prior to that, I was a clinical director at an interdisciplinary pain program in Portland, so really understand the value of interdisciplinary and increasing access to multidisciplinary care. It's also co-chair with Ruben for the Oregon Pain Management Commission, and Michelle and I are doing the ECHO for opioids and pain at OHSU to uptrain some of the PCPs around the state of Oregon. So that's really interesting. My voice at the table is always to promote pain education, because I don't think we can taper people off opioids without the providers and the patients better understanding pain. So we did the Oregon module that was released last year, and then we just released this year the patient that Michelle was also involved in, patient education videos and handouts that are all on the OPG website, and there's a new patient education module that's going to be coming out this year as well. So most providers don't know about them, and so if we're going to do this, we should be doing it all at the same time.
That's great. Thank you so much. Helen.
I'm Helen Turner, and I'm here wearing two hats. One is from the Oregon State Board of Nursing, because physicians aren't the only prescribers of opiates. And I review discipline cases at the board related to opiate prescribing. So I think this is a really important topic, because my background also includes being a past president of the American Society for Pain Management Nursing. So I've been in the pain world for about 20 years. My second hat is my clinical practice is pediatric pain management. And while we talk about guidelines not applying to children, despite what we say, what we write, and what we market, they still get applied to children. And so we have to be thoughtful of that as we have this conversation. Because I deal with that. I currently have probably about 8 kids on chronic opioid therapy. And to think about weaning some of them is challenging at best.
Thank you so much. Safina.
Hi, my name is Safina Qureshi. I'm a family medicine and preventive medicine physician, and I'm currently medical director of Columbia Pacific CCO, and I see patients at OHSU Campus Clinic. And my perspective comes, like some of you, from the primary care perspective, both, of course, prescribing, tapering, managing chronic pain for patients, but also from a medical leadership perspective within organizations, and how we implement organizational and or state or whatever guidelines, and how that actually happens within an organization, and the supports that are needed to support providers and staff and patients as it relates to that. And then from a CCO perspective, how we do all of those things, but on a regional level. And like everybody, what I've seen is this go from one extreme to another extreme, because it's such a difficult topic that it's easier to be black and white. And I think, like everybody, I'm going to say the same thing in a different way. I think this will be successful if we find a way to bring that art of medicine back in, but in somewhat of a concrete way, to have that be translatable both to the providers and to the community at large.
Great. Thank you so much. David.
Hi, I'm David Labby. I'm currently the Health Strategy Advisor for Health Share of Oregon, which is the local CCO in the Tri-County area. I'm a retired physician. Before I moved to this position, I was the Chief Medical Officer at Health Share, and before that, I worked at Care Oregon for many years as their Medical Director. What I bring to this conversation is since we're talking about decades, several decades of work in terms of primary care transformation. I can proudly say that I have written more guidelines that were ignored than probably anybody else. And so, you know, there was in the early days, we thought guidelines were the end-all and be-all. All you had to do was, if you wanted better diabetes care, was write the guideline on diabetes, and I did that in the 90s, and they were completely ignored, pretty much. And there was actually a move from guidelines to practice transformation, really changing systems. So I think, and I've learned a lot about how, I think what we're doing now is we're trying to change the standard of care, and guidelines play a role in that. And so where you set the guideline, what it addresses, who it addresses, how it works, what it's trying to do is part of the art of doing guidelines that are not ignored, and we have some of those. I think we are at a tipping point at this point. I think, if you think about the last 5 or 10 years, there was the epidemic that we all responded to in a very draconian way, perhaps. We rammed through CDC guidelines, we got state guidelines. There is now, which I think was appropriate for the time. I'm not going to go over the whole history, but now there's pushback, and there was always pushback from the beginning, and the pushback is really, and everybody's talked about this, how do you get that balance between our mandate to use evidence, to reduce risk, to do no harm, and the balance between being completely patient-centered? How do you do that? And I think that the Ruben spoke, started off this stream, which is, how do these guidelines actually send a message to primary care providers so they feel comfortable in a zone where they know what they're doing and they're balancing things? I don't think we're going to get it completely right, because the other thing my voice at the table is always to say, a lot of this isn't controllable by medical care. A lot of this is about your relationships to your family, to peers, to community. We are not going to solve all of the pain problems, whatever we do, whatever happens in clinical practice. And how do we think about what our ultimate goal, which is to have our patients have the highest quality of life possible? How do we think about that? I don't believe we're going to get there in terms of this guideline, but we certainly ought to sort of poke at that edge to make sure that we're not sending out yet another recipe, which is an incomplete recipe, and the bread won't rise. So I think it's going to be a really interesting exercise to figure out how we get this as right as we can for the moment, because that's all the guideline can do.
Thank you, David, so much. On the phone, I know we have Roger. So Roger, could you please share your perspective, your name and perspective?
Sure. I'm Roger Chow. I'm a professor internal medicine at OHSU. I do health services research. I direct the Pacific Northwest Evidence-Based Practice Center. We've done, of course, many systematic reviews and other policy work on opioids and addiction in general, including the CDC guideline and the prior APS, AAPM guidelines, and a bunch of other things. I'm also a primary care clinician, and I manage patients with on opioids. I guess I don't think I have anything new to say. I mean, actually, let me step back. I first want to say that I think there's been a false dichotomy that's been perpetrated about that tapering is somehow not patient-centered, and I think we have to be clear that tapering and keeping patients safe is absolutely what with goals of patient-centered care. We do need to make sure that what we do in terms of tapering recommendations is consistent with evidence that has come out since 2016. That we, and we have to recognize that there are ways that the CDC guideline has been implemented and used that are just not consistent with what the guideline says. The guideline doesn't say to taper everyone over 90 MEDs. There's nothing in the guideline that proposes or suggests that mandated or mandatory tapers should be done. it's all based on individualized risk assessment. So there are ways that the guideline has been implemented that are not consistent with the guideline. But like I said, we also have new evidence, and I want us to make or try to develop policies that are consistent with the evidence, and like I said, help us manage patients in an individualized fashion. I think we still have to bear in mind that opioids are associated with very serious harms, and that we can't ignore that. This is an iatrogenic problem, and it's our responsibility to, help manage this.
Thank you so much, Roger. Do I have on the phone any other task force members? Amy, are you on the phone? Jonathan, are you on the phone? Any other task force members on the phone? Okay. All right, so I really appreciated all of what you shared and all the sort of listening that you all did. And obviously there is a wealth and breadth of experience in this room. And so the point of the next number of months is to mine that. And we're going to be, a number of you sort of raised and surfaced sort of things that you think, well, we got to do, we should consider this, and we should consider that, and the guideline should be this. That's the conversation we're going to start today. At least, what do we want to really be paying attention to as we craft these guidelines? What are the key things? And then we'll be talking about what should be included in the guidelines as well. Before I turn it over to Katrina, I just wanted to take 5 minutes tops, and this is a group of folks who you all haven't been in a room, all of you together, doing work together. So I just wanted to take a few minutes and sort of see if there are any ground rules sort of that you wanted to establish as a group. And by that, I mean, there are standard ground rules that folks use all the time, listen when other people are talking, sort of step up if you're loath to talk, sort of step up. If you talk too much, maybe step back, listen respectfully, be present. Any of those things. I could spew a bunch, but I'd really like to hear from all of you if there are a few things that you want to be sure as we have our conversation. We're going to be working together for a number of months, right? And so as we have our conversation, are there things that you really want to be sure as we work together, what's really important to you?
One thing that comes to mind is that we lean into differences of opinion rather than avoid them, because I think oftentimes that's where the real substance and where the real questions that others have will arise.
That's great. Thank you. Anybody else?
I don't have anything more than the standard that you outlined.
Sort of the ones that I outlined, sort of respectful, and I can sort of write those up, sort of respectful communication, stepping up and stepping back, and I sort of shared what that was. Be present, participate, all of those things. Anything else? Okay.
I have one to add,
Dana,
Diana, if I
please.
can, before we go.
Absolutely.
I sent an email about this, but I just wanted to re-bring up our communications with each other. And this is our first time together, so I wanted to get it out in email, but I want to share it here in public. So our task force doesn't technically meet public meeting law, but we are fulfilling this meeting as if it is, because it's really important to us that this is done in a public, transparent process and is really an open conversation. So to that end, we're posting meeting notices, we're posting all of our materials, and we're allowing time for public testimony at all of our meetings. That transparency is really critical for us at OHA in our support of this process. So in order to maintain that level of openness, we just ask you not to have communications online with each other. If you have materials or information you want to bring, we ask you to have those communications in our meetings. If you have materials that you want to share and discuss at a meeting, please get them in advance of the meeting so we have time to post them to discuss. So please let me know if you have any questions about that, but again, we really want to make sure this is a public opportunity.
So just a clarifying point, there's a group of us, some of them in this room and some are not, who've been working on tapering guidelines independent of
Yes,
this,
it's
and
different.
our work is kind of going
Correct.
to continue in parallel.
Thanks for calling that out. Yes, of course, work you're doing outside that may relate to this work but isn't specific to the task force and your participation here, by all means you can continue those communications. But if it pertains to work we're doing as a task force to develop these guidelines, please keep that in the public, transparent domain.
Any questions about that? And if you if you're not sure, check in. We also want to make this easy on you all because you're giving your time, which we really appreciate. But feel free to send us information and say, I would love to get this out to the task force. And we will try not to clog your inboxes. We'll package things together and get it out to you.
And who would send that to the three of you?
So why don't you who do the meeting invitations come from? Do they come from Lisa Bowie? So
we should
send it to the generic email box.
Yeah, Lisa, will you introduce yourself?
Hi.
Tell them who you are.
Well, some of you know me. I'm Lisa Bowie. I'm in Dana's team. I'm the OHA Quality Improvement Director. I will also be help supporting this group and is your primary contact person for all fun things of travel and just meeting logistics. You should all, and maybe I'll put it on a little post-it paper here, the generic email address, but that's the stuff where you send your applications and the correspondence. I usually, again, try and just use that one email box for everything that pertains to this meeting, then my other work email address. But if, in fact, you do send it to the work email address that says Lisa, I honestly just forward it to the other one.
Should we introduce all the OHA staff?
The OHA staff, Ash, would you introduce yourself?
Yeah, hi, I'm Ash Kane. I'm Dina's assistant. I started organizing the meeting, but I'm actually leading it over a year.
Jonalise.
Hi, Jonalise Corbett. I work for OHA and I support Trevor Douglas. We're at
Great.
Hi, Sarah England, Strategic Communications Officer with the External Relations Division at OHA.
Thanks.
Hi, I'm Laura Chisholm and I'm the section manager for the Injury and Violence Prevention Program. I work very closely with
Good. Thank you so much. All right. The other thing I meant to say is this is a 2.5-hour meeting, and I always give breaks at 3-hour meetings, and I'm not, and so I was sort of back and forth. Here's what I'm going to say. We're not going to have a formal break, but I urge you all to take care of yourself. If you need a break, get up, do what you need to do, and we'll just sort of see how it goes. And again, your meeting, not mine. If you want to revolt and say we want a break, I will honor that. But let's see how far we get. I want to be sure we have as much time as possible to hear from all of you today, in addition to the context setting, which is where we're going to go right now. And Katrina's going to talk a little bit about the formation of the task force, and we'll also, I think, get to Roger's query about the other work that OHA is doing.
Yeah, so thank you. Many of you have heard me, I usually present slides and this kind of thing, and we decided not to do it for this meeting, although I'm happy to share data. We actually have a very nice data dashboard that really, it's available on our website, that shows what's happening with both overdose deaths as well as hospitalizations and prescriptions. So all the data that I'm talking about is available. As you know, we've sort of gone here. It's taken us, almost 20 years to get to this problem, and we're working our way out of it. The drug overdose deaths, if you look in general, started to increase markedly between late 1999 and 2000, and then almost increased fourfold up until the late 2000s. The bulk of that was from prescription opioids. A lot of when we look at heroin deaths, they were pretty flat along that time. There was an increase, but they were pretty flat. Lately, we've seen an increase in fentanyl, but that's why we're here, is really, and I can't remember who said an iatrogenic problem, maybe it was Roger, but that's part of the reason that we're here, and we look at the prescribing guidelines. Even though we've started to see an impact and opioid overdose deaths have declined, they're still 3 times higher than they were in 1999. So we are not at baseline. I know you all are aware of data from Europe, for example, and opioid overdose deaths. They do not have the same level that we do here. And I don't think it's because Europeans have less pain. I think it's because they're managing their pain differently than we are in the United States. So about, I guess it's 4 years ago now, we developed, along with partners, an opioid initiative framework. And the idea here, and many of you have alluded to it, is it isn't just about guidelines. We had 4 primary kind of categories that we looked at. One was improving access to non-opioid, and I might say non-pharmacologic pain management, to really focus on what are the things that we can do to support pain treatment that don't involve a lot of drugs that are potentially harmful. So that was the first piece, again, very patient-centered, improving access to pain management. The second piece was increasing access to medication-assisted treatment for people currently on opioids, as well as naloxone rescue. And again, I almost see every naloxone given as a failure, right, because the person has overdosed. You're preventing death, so it's a success that way, but I would really love it if we never had to use naloxone. So those were the first kind of two buckets. Then we had one around decreasing the amount of opioids in the community, and that's where guidelines came into place, both the chronic guidelines, and again, Roger Chow was one of the co-authors of the CDC guidelines, and then we have Oregon-specific guidelines that started with the CDC and looked at a couple of other areas. I'll talk a little bit more about that in a minute, but also things like drug take-back, and there's been a lot of discussion about that, just so that we don't have as many of these pills out there. I will say one of the reasons in Oregon is that we are among the top 5 states in non-medical use of prescription opioids. So this is from surveys. If you look at the National Survey of Drug Use and Health, people report that those leftover drugs in the medicine cabinet are being used for non-medical purposes. So when people say, well, you know, a prescription and I don't take it all and whatever, that's understood, but then you need to be able to get rid of it, and in my perspective, not be prescribed too many pills to start off with. I didn't say not prescribed any, but not prescribed too many to start off with. And then again, our data dashboard, so that we're constantly having a feedback loop about whether things are improving or not. So if we look at the guidelines, the real purpose of guidelines, and I think David said it well, it's like, you know, the government, we know how to do guidelines and reports, and then they sit on a shelf. But the real purpose here is to change the conversation about pain management. Guidelines really are about a communication, how we communicate around what we're doing, and it's also to serve as a tool for folks. They are not meant to be a statutory requirement. I will say, and you're probably all aware of this, many states have prescribing guidelines in statute. So the fact that we are having some of these guidelines that are now available, we put them on the web, they aren't in statute. Yes, they set a standard of care. But again, in my mind, even though we're in the middle of legislative session, I think when things are in statute, it gets to be difficult, because then how do you change them? You have to actually change the law. And so having guidelines that then can be amended or changed as we learn more is much more effective than having something in statute. So we started off with the guidelines to address chronic pain. Since then, we have also ones for prescribing for acute pain in dental settings. We've also developed guidelines around pregnant women. This wasn't just for prescribing opioids for pregnant women. This was looking at pregnant women or women who might be using opioids or have a substance use disorder who then became pregnant. So these guidelines are looking at that. We also know there's many provider groups. For example, the OSEP, so the Oregon College of Emergency Physicians, has their emergency system guidelines. We're looking at some for surgical settings, et cetera. So again, we really are looking to practice groups to develop those, and again, we're serving as a convening function, but understanding that the experts around practice really is in those different practice communities. So all of the guidelines explicitly call out the need for compassionate care while tapering, and I'm happy that many of you really talked about that balance, because the purpose of these is not draconian. I understand that some of the systems have perhaps implemented them in this black and white way, but that has not been the purpose of any of these guidelines. So I think that especially with this group around tapering, we really need to emphasize that this is the art of medicine. There's a science behind this, and we want the evidence base, but there is the art of medicine is behind this, and not every patient, or actually most patients aren't going to respond to exactly the same things, because people have an individual story. So we have made progress. Again, this is all on our data dashboard. Oregon is one of the few states that have actually seen a decrease in opioid, both in prescription opioid deaths. The national rate has continued to increase. We have not seen that in Oregon. It's declined. The rate of Oregonians who are receiving an opioid prescription greater than 90 MED, this is morphine equivalent doses, it's declined by half. It was at 16 per 1,000 residents, and now it's down at 8. So the proportion of patients that are on a higher dose, I'll define greater than 90 as a higher dose, has been declining. But again, there's still 10 in 1,000, or 8 in 1,000, I should say, who are still on high dose and are potentially at risk, so potentially unsafe dose. So one of the things that we're really concerned about, and everyone says, as you see a decrease in prescription opioids, are people going to go over to heroin? I mentioned that we hadn't seen the same increase in heroin in 2000 that we had with prescription opioids. But back in 2005, 2006, we started to see an increase in heroin deaths. But those have been pretty flat since 2007. So again, I'm very concerned about people dying of any drug, including heroin or prescription or whatever. But that has been flat even as we've tapered down off the prescription opioids. What hasn't been flat, of course, are those fentanyl deaths. Now, the fentanyl that's coming into the state is really concerning because it's not the fentanyl that's been using the patches or the end-of-life care, et cetera. It's fentanyl that's illicitly manufactured, primarily in China, but in other places. And often people don't know that they're taking the fentanyl. It may be contaminating, if you will, other drugs. Recently, I think it was on the news that cocaine, many of that has been cut with fentanyl. It somehow works synergistically. So I think many of the folks who are using illicit drugs may be getting fentanyl and not even knowing it. What we're doing around distribution, of course, that's a whole law enforcement issue. So we're not here to talk about that specifically, other than to say that the response really takes, it's multi-sector, and we need to be working on the supply of illicit drugs and identifying that as well. So part of the reason I'm talking about all of this is that these guidelines, if you will, or coming up with standards, are one piece of a much broader initiative. This isn't going to solve the problem in and of itself. This is one piece of it. I do think, and somebody had mentioned this as well, we have a sort of an effort within OHA to look at this. We call it a syndemic. That's kind of a jargon, but it's multiple epidemics that are happening simultaneously. And the idea here is that the same folks who have many of the adverse childhood experiences or are living in poverty and racism, et cetera, a number of those, food insecurity, et cetera, housing problems, are many of the folks who are using drugs. And then when they're using drugs, there's also at risk for, if it's injection drug, obviously overdose there, and you talk about bloodborne infections, and even just skin infections and all those kinds of things. Hepatitis C, we have a big initiative on that. But it's just to say, again, that we might be addressing one problem, but we know that it's much of a part of a much broader issue. So that, I think, lays kind of the groundwork of why we're here. As I mentioned in the beginning, this is really a convening function, and we need input from all of you to help address this as we're working in this much broader scope of things. Just one last thing is that we do, similar to what many folks have said, drug use or opioid use, whatever it is, really is on a spectrum. There's use, and many, or I would say most of us, have gotten an opioid at some point. I certainly did after my C-section, and I'm very happy that I was able to have something that could address that kind of acute pain, right? So there's use, and then it gets over to misuse. I mentioned the medicine cabinet. Certainly dependence is a different, tolerance is something different, and then there's the addiction or the substance use disorder. You all are very familiar with this, but I think we need to be very we need to be very conscientious about making sure that when we're addressing, we use the right language, because I know we've had a lot of comments, certainly on the web, or saying, well, you think we're all addicts, and it's just because I need my opioids for pain. We're not talking about people who are addicted necessarily, although that's a piece of it, and folks have talked about just because someone is on high-dose opioids, they could also have a substance use disorder, but they might not necessarily. And so I think we need to call out those things in our guidelines.
Thank you so much, Katrina. So Dana's going to, does anybody have any questions specifically? Not comments necessarily, but questions, and then we're going to hear from Dana about how this all interplays with some other stuff that's happening in the state.
Yeah, Katrina, can you just refer back to the heroin overdose, because there was the email that went around from the Stanford whole group there referencing that they felt that there was actually an uptick in heroin overdoses in the state of Oregon with the decrease in opiate prescribing between 2015 and 2016.
So I'm looking, I've got the data right here, I can show it to you, I can send out a link to our data dashboard, and so, the lines go like this, right? And so I always say that 2 points doesn't make a trend. The biggest increase in heroin overdose deaths was between 2005 and 2007, and we saw about a 4-fold increase then. Since that time, it has gone up or down. So there was an increase between, I'm looking here, 15 and 16, but it was a slight uptick. Meanwhile, the prescription opioid overdose deaths was declining pretty. So if they were totally correlated, you would see this. And we're not. We're seeing this and a little bit of up and down. But it is concerning. As I said a minute ago, I am concerned regardless of what drug people overdose from. So that's part of the reason while we're tapering people off. Someone had mentioned buprenorphine or other things. This doesn't mean that you don't offer any either medications or alternative therapies. So yes, I'm concerned, but I don't believe that's a reason for us to not taper folks off high dose of prescription.
And we'll send the link to the data to the whole.
We love our data
They were
dashboards.
suggesting that the data was different, so I wanted to clarify.
We'll send it so you all have that. I want to hear from Dana. Do you want to share with folks about sort of the context and Roger's earlier question about how the work of this task force intersects with other work that's happening in the state?
Absolutely. I mean, I think before I get to that specific question, though, I just wanted to speak to the need of this, why we're convening you all and the need for this work. Many of you have already spoken to it already, so it would be a bit of repetition. I think the harms associated with, the potential harms associated with opioids have become clear, but the harms, as shown by the evidence, for example, about tapering are less clear. And there has been a lot of work happening around the state where we're looking to what exists as statewide guidelines or consensus around tapering that is missing, that we think you all, with your expertise coming to the table, can really help to inform a void space. What does the evidence say? What does your experience and expert opinion say to help provide this tool? I heard mention a lot about this gray area, and I think that hones in on a little bit more about, again, the need of your work that will be not black and white and a difficult set of work, but clearly important between now and the fall. We have heard a lot through different areas of work that individuals want to have both autonomy in terms of their prescribing and relationship with their patients, and patients want patient-centered approach that's compassionate, and they can have some expectations in the relationship as well. So that is another need we've heard. I've also, I think as you all spoke to, or many of you have heard over and over again stories about this angst that providers who are prescribing have about this concern that they need to quickly get people off, and that does not leave the patient in the best circumstances in terms of treating their pain and having access to supports that they need. So those are all the reasons that you've already articulated that we are bringing you together, and appreciate the commitment of the time that you've put forward moving forward in this work together. One of the areas that has been work underway that in our state that has, I think, come to a clear understanding of some of the challenges and lack of this resource that we're pulling you together is some of the work being done around Medicaid coverage. And I want to call that out as a separate set of work in our state. The Health Evidence Review Commission is a standing authority around setting Medicaid coverage, governor appointed. OHA helps to staff that work. And in the last couple of years, they have been working on different coverage guidances that relate to pain management, and have called out in that coverage guidance work related to tapering. That is a separate policy body who has their own statutory authority. We are not a recommendation body to that group. So I just want to make it clear that they're separate, but I also want to say that when the HRC does their work, they're looking for evidence, and where and they're looking for expert opinion, and they look at guidelines. So I don't want to say that our work is in a vacuum. I hope that your work is a tool, be it for the HRC in the future as they continue to do work on coverage guidance, to organizations like hospitals or health systems or education. We do not have authority outside of pulling together broadly endorsed guidelines based on kind of your goals that you brought forward here today. We do expect and hope that informs everybody's work. The HRC's work is being done through also a public policy process. They are meeting Thursday, so I just want to acknowledge that, and are addressing pain guidelines and Medicaid coverage, and you are all welcome to attend that. And all of the public input that has been garnered through there is also present as part of that meeting. And I guess so ultimately, hopefully that defines the difference. I think, again, we are really hoping to support patients with safe, compassionate care that is patient-centered, and we hope that is the outcome of this work. And we just so value. I didn't get a chance to share my background. I'm a pediatrician. I have not done a lot of work on substance use disorder or opioid tapering, and really I'm here to help shepherd and support this work to be successful based on the work we've done and real clear need that we have for this work. So thank you. And Roger, I want to make sure, if I haven't already, that you can articulate any other questions that I didn't cover.
No, that was helpful. I guess I still have, I guess, a concern that what if so it sounds pretty clear that we're independent of whatever OHA is doing, but I have concerns about if there are different guidance for Medicaid patients versus the rest of the state. I think that creates confusion, and it also is not an ideal situation if people are being treated. I mean, I think for many clinicians that would be problematic if there is, different guidance on tapering for somebody just based on their insurance. So
thanks, Roger.
Anyways,
let me just clarify. So yes, independent from the HRC. And on top of that, I would expect that the HRC will look back at work being done, new evidence that has arisen, new guidelines that are in place, and can update work that they've done on coverage through their public process of policymaking. So I hope that clarifies that. They have historically looked at endorsed state guidelines and the guidelines done at a national level to inform their work, and I would expect that would be the same case with the work that comes out of this task force.
Please, David.
So would it be useful at some point in our deliberation to have somebody from the HRC sort of give us a perspective of what they're doing, where they're going, how they're thinking? So, because the point being made is, as a provider, if you have two sets of guidelines, to put it mildly, it's just going to create confusion. And so how do we, I think somewhere along our process, there needs to be an attempt to at least understand where each other is going and what each other intends on a transparent basis, so that rather than we just have parallel processes and we'll see what they do and they'll see what we do and maybe the twain shall meet.
Absolutely, we can definitely do that. We can have HRC staff for sure come and speak to that.
Okay, Paul and Minnie.
Just again, I'm asked that as part of policy that we make a distinction between wean and taper. This is a taper.
Yes, correct.
Roger's involved in a taper group, and I'm involved in a taper group. Not a wean off of opioids group.
Yep.
And so if we could understand that terminology, that we use wean, so maybe OHA is a wean group, but we're talking about tapers.
Right, that this is taper. Exactly.
So for those of us, especially I work in the VA, I know all the media lingo. What does HRC stand for?
The Health Evidence Review Commission.
Okay. And that's part of what body?
It's an independent policy-making body that sets coverage for Medicaid in our state, appointed by the governor.
Oh.
We can get you a link to the HRC website. We can have them come speak to their role in the future if that would be helpful.
I think the concern that was being raised on the phone is a very valid concern when we talk about disparities in healthcare and access to healthcare, especially when we're talking about a Medicaid population that inherently is socioeconomically more disadvantaged and therefore does not have as much choice in selecting their care providers and the care that is covered by the state. And so I would really support the idea of, I think that these two task forces need to have a meeting of the minds to prevent essentially having a two-tiered set of recommendations based on what will or will not be covered. One of the challenges with decreasing opiates, tapering, or weaning opiates is that opiates are relatively cheap.
Yep.
The alternatives are not. And so I think it's part of a much bigger global issue that, while I realize the task force can't address every aspect of this, certainly having two task forces working on fairly similar outcome recommendations, I think the two should definitely, I don't know if it's appropriate, but intersecting of the two rather than having either body come out with recommendations. Well, maybe opposite, or may not be financially sustainable or supportable, and then again, it goes to disparities and equity in medicine.
So let me hear it from Dana, and then I think Ruben has a comment. So Dana, do you have a...
Yeah, no, I appreciate all the comments. And absolutely, we can bring forward and carry those conversations forward. Likewise, if appropriate, we can have someone from this group at some point also bring information to the HERC through their public meetings. I think in part today we were wanting to really set the fact that this is a group to set statewide broadly endorsed guidelines based on your expert opinion, not an OHA set of guidelines, but a broadly endorsed as building off past guidelines work we do. And yes, expect that will and should inform the work of the HERC and others who are setting policy at the state or agency level. So yes to all of the above. The work I will just call out because of that the HERC is considering right now is looking at considering expanded coverage for certain individuals with chronic pain and trying to explore the opportunity of access to broader sets of pain therapies beyond opioids. It has been a long process, and it will continue on after this immediate discussion and will be informed by this future work. So, but I appreciate the interest in making sure, the disparities discussion and making sure that there's connection points.
Yeah, can I just comment?
Katrina, then Ruben, then
just
we'll go
briefly on
Katrina.
that, but I think one of the things that was missed in a lot of the media coverage about it was that HERC was really looking at, for example, the lower back pain guidelines. What are the other things that work? What got the coverage, of course, was the tapering or weaning, which, again, it is about tapering. And so I think that was unfortunate because it really was about what are all of the things that can be offered, et cetera, but what hit the news, so again, that balance of really, and Medicaid is 25% of the population, but is only 25%, which means that's important. But part of the reason that we're looking to all of you is not just the Medicaid piece. It really is what would be a standard across the state within all different practice settings, et cetera, knowing that Medicaid will likely pay attention to the work that this group does.
Ruben.
So that's what I wanted to clarify, because you started off saying this is not an advisory group to HERC. You made that clear.
Yeah.
So whatever guidelines or whatever comes out of this, who actually does it inform and under what obligation is the state or any
Yeah. So I can talk a little bit about the past guidelines, which is what we did was to put them on our web. So hopefully they aren't on a shelf, they're on the web. But what we really said is then it's up to various health systems and practice groups, et cetera, to endorse the guidelines and figure out how they're going to be implemented. So the other thing that I said, at least about the past guidelines, was actually writing the guidelines was easy. The much harder part is implementing them. And there's other initiatives that we had. I was talking about all of the different things that we've done within the public health division, and it's true throughout OHA, working with different practice groups, trying to transform the practice of medicine, of which guidelines are a piece. So the idea, again, isn't just that you write them, put them on the web, you can download them, but it really is that they need to be figuring out within the different practice settings, how would you implement them and how does that make sense?
So is your hope that as this gets clarified that the CCOs and other insurance groups and other people practicing in Oregon would take those and create practice policy?
Yes, could look to them, again, as a tool, number one, and second, sort of as a communication tool about what we're trying to do. And so that would be the goal. And again, you mentioned the VA is having things. So is there a way to look, and I don't know what percentage of the adult population is in the VA system, but that's a chunk as well. And so different practices, and we've seen that with the other guidelines. We have regional opioid task forces throughout the state of Oregon that are looking at their own set of guidelines. I know Safina can talk about this and Jim, but that different settings, they might have to be implemented different. We don't have, a single healthcare system here. We have multiple. And so the guidelines really are around a standard, but they are just guidelines or recommendations. They are not the letter of the law.
So we hear from Katrina and then David.
Well, Katrina already said is I was on the chronic pain task force, and the goal was to increase access to multidisciplinary care. The opioids was just a small component. So.
And it got all the coverage.
Yeah. So.
David.
So I mean, my guess is that the most important thing we'll do is we will create a guideline where there's nothing now. So the idea that there is a guideline out there, that actually there is a body of knowledge or a body of experience that will help me do what I'm doing, is a new concept in practice. I mean, most providers, when we started this, they were making it up as they went along. They had no idea. There was no conversations. I think the OPG conversation was kind of even late in the day. I mean, there was people like Paul who were doing it, you know, had a lot of experience, but the average person didn't have, and the idea that your practice could actually have a guideline, you know, that's a new concept out there to the world. So I think that's actually what we're gonna do. And my suspicion, like every other guideline, is that the most progressive clinics will sit down and say, well, you know, we want to make our own version of this and we'll adopt it. But that without something like this, that won't happen. So I think that's really what I don't think it's CCOs. Actually, I think CCOs are probably fairly irrelevant to this.
Let me hear from Kim and then Katrina.
So I sat on the chronic pain task force as well, and then I'm the chair of our regional task force. So what then we did is we took those guidelines and worked with our region, both the health plan and all of the medical players, and really embedded those into practice. And I'm actually proud to say that they are part of practice. Now we're doing that with acute pain guidelines. What I will say and appreciate is that it's not a legislative body of work, that it does allow for some clinical autonomy. And I've appreciated that approach for Oregon and respect for the providers' independent practice. Implementation of guidelines is not a joke, it's hard work. It sort of has, you know, the structure and then the wiggly edges around it for the variance between the regions, but it does provide an important framework. And just lastly, I want to say I can't emphasize enough the importance that the HERC and this task force do come together and have some agreements on what that looks like. I think that's very important for the health of our providers in our state.
That's great. Thank you. Katrina.
Yeah, so I was just going to make a brief comment about this as well. We're aware that there are other guidelines out there, other resources, and so that's part of the homework that we will be doing. So we want to be sure that, we want to hear from you all what you know and then what we might be missing. We didn't want to come in with, here's a draft, you know, go ahead and endorse it and we're done here. We really want it to be interactive, as I think is spoken, but we do have homework to do because we're aware that there are other tools out there, other guidelines, et cetera, and so we will be doing some homework around what these different ones say and what the elements are, et cetera. So I just want folks to be aware that we're not starting at square zero, if you will. There is a lot of work that's been done, but the purpose of this is really to get us all together and make sure that we understand what those elements are.
All right, so we're going to transition to hearing from more of you. I'm going to have to ask you guys to turn around. I'm sorry, because I don't have an easel. But before I do that, Lisa Bowie, can you tell me how many people we have signed up for public comment, please? Because that's going to...
That's in the room.
We have no public comment in the room. Okay. All right, so then we have a little more time. And if someone does come in for public comment, can you let me know? Because this means we have a little more time to do the work that you want to do. So I apologize that I don't want you to hurt your necks, but I don't have an easel. So I want to write. Because here's what we're going to do. We're going to spend the rest of our time really hearing from all of you. Okay? And the first thing I want to hear, right, we need to start setting up. We're not going to write the guidelines right now, but what we need to do is start to set up some sort of frameworks or sideboards or things that will help us as we move forward and will help us figure out what you want to put in the guidelines and how you want to put it, what has to be included, that kind of thing. But the first question, and you can see it on the agenda, is to spend, and some of you have already shared this, sort of what are the principles that should govern these guidelines? And this is what I mean by principles. What I mean, and I'll just use examples that you all have. So any guideline, guideline principles, any guideline, I'm just going to put this up because I've heard a number of you said it, has to reflect compassionate care. Right? So that if you put the guideline through a filter, one of the things that I think I heard you say, and tell me if I'm wrong about this, is that it has to be compassionate care. It has to reflect compassionate care. So what are the other things? What are the other principles? What are the fundamentals that have to be present here?
Flexibility.
Say it again?
Flexibility.
Flexibility.
Trauma-informed.
Safety.
Safety. So when you say that, you mean they should be safe, like, just say what you mean when you say safety.
Well, when we're talking about opioid tapering, opioids we know are generally have a lot of harms associated with it in
So
terms
to have
of
to be sure it's
evidence.
safe for the patient.
And communicating the safety aspect.
Great, thank you.
Accessible.
Accessible. So say what you mean by that.
It's twofold. I think that we can come up with the most beautiful, pristine set of recommendations. Patients can't access those resources or access those providers and those skill sets, then we've accomplished very little. So whatever we propose, we need to make sure is something that most healthcare systems and most patients will be able to actually reach for.
Great, got it. Please, Ruben.
Medically realistic.
So say what you mean by that.
Well, I think all of us who practice, we see really bad guidelines come out about lipid lowering or about blood pressure. Just new guidelines came out about blood pressure that physicians are basically refusing to implement because they don't make sense medically. They don't fit with our experience, and they're hard to do. The benefit doesn't justify the effort. So
I think it's really important to have like an integrated approach and have the patient buy in, so you can have some realistic expectations that are set up. So not just say, okay, I'm going to do a 10% paper or whatever number you pick in a month. It has to be very patient driven, and again, be compassionate. Where this is going to require a lot of follow-ups on the provider's part as well.
So integrated approach, but is there something else?
So just setting up the expectations of the patients beforehand, before we even start, to have a meeting where we talk about why we're doing this. And I've seen that in our practice where, some primary care providers saw the guidelines and went ahead and papered without really telling people what.
So sort of patient-centered?
Patient-centered.
Evidence-based and data-driven. Evidence-based and data-driven. Gotta do purple.
So, following up what Paul said, is it a principle that these are tapering, not weaning? I mean, weaning might happen. You get people totally off. I'm throwing it out there. I'm sort of channeling because, again, I think that was a piece that was, is potentially.
Is it focused on tapering?
Yeah. Well, what I was saying is that tapering, the expectation is not that people are necessarily weaned off. It's a question.
I'll throw it out there. So Roger and I have talked back channel.
Yeah.
Roger and I have talked back channel about this. If you look at a Medicaid patient with back pain and an equivalent identical patient, same age with back pain who has Medicare, there are two different guidelines. It's a double standard. And that drives all of us crazy. So I hope this is a taper guideline, not a wean guideline.
Yeah, that's what.
I think tapering on a safe dose is what should be, for somebody who has no risk factors. Maybe a 90 milligram dose where they're functional and are fully participating in whatever is required, versus somebody who is really at a very high risk of an adverse event. So at the VA, we have databases that we look at suicide risk, because that's what we've seen, that as we started to taper patients, the suicide rates are starting to go up. And our patients already have mental health issues. So making sure that we're looking at all these aspects.
Now, does that go to the safety piece? Yeah.
I also think that
Safe doses.
Safe doses. Go ahead. I'll hear from Jim, and then Ruben, then Michelle.
The guidelines need to incorporate appropriate assessment. You really can't do a lot of this unless you have assessment built in.
So, Jim, I'm going to say, you can tell me if I'm wrong about this, But the next discussion we're gonna have is what has to be included in the guidelines. And so to me, and you're more of an expert than I am by far, but is assessment more of, like you have to have an assessment piece in the guidelines? Does that,
As opposed to a guiding principle.
as opposed to a guide, I mean, I don't,
Sure, yeah.
I'm gonna try that okay, then I had Ruben, then Michelle.
So this is back on the issue of tapering versus weaning.
Yeah.
If you put anything about people must be weaned to zero,
Yeah.
you're just, it's
Yeah.
not realistic. You'll get a backlash, and that's
Yes.
what happened with the HERC line,
Right.
low back line. People focus on the idea that everybody by 18 months should be off opioids if they were on, and what you end up is nothing.
Right. Right.
People look at it and say, I can't do that.
So let me ask this, just to, because this has come up a number of times now on taping versus weaning. So guideline is focused on tapering. Do you want to explicitly say not weaning? Or do you, I mean, is that, Jim, do you have a comment on that?
I do. So if we go back to the risk benefit, the safety piece, as you're tapering and you do periodic assessments, at some point you may get to the place where, oh, it looks like the benefit has outweighed the risk, and we're at whatever dose you're at, well then, you can stop there if you have.
So just a focus on tapering is important.
You might taper to
You
zero.
might taper to zero, but it's not,
safe
it's
dose.
the language that's important. So let me hear from Michelle and then Katrina.
I was just gonna say clarifying language, like making everything very clear with the assessments also, and the language around dependence versus, SUD, OUD, all of the language needs to be very, very clear and well written.
Yeah, good.
This goes back to also understanding pain. If we're helping them understand the benefits perhaps of tapering, then they also might be helped by a better understanding pain and other elements that they could do proactively to manage it.
So what does that mean? That means in the guideline, there has to be some kind of education has to be built in, or?
Yes.
Is it like pain science? Is it like, I sort of call it contemporary pain science, like a focus on sort of calling it out, but I think it's worth calling out specifically. At the very least, informational for patients.
Hi, this is Roger. Can I ask a question? I'm not, I feel like compassionate sounds good, but it's a loaded term, and at least in the, discussions, going on right now, it's often meant to be, not tapering. I mean, it's kind of it's used as the opposite of tapering. And I feel like we have to, I'm not exactly sure what is meant by compassionate, and so maybe just, can we articulate that a little bit better? And I think, and I guess where I'm coming from is that I don't think there's anything compassionate about leaving people on drugs that are harming them or, could potentially harm them. And so I think we just need to be clear what that means, and again, not use, I guess, terms that could potentially be loaded, or at least be clear about how we're defining some of these principles.
So Helen, I'm gonna come to you in a minute, but let me see, does anybody want to sort of chime in with clear language around what?
Patient-centered.
Patient-centered.
I think
Which we
patient-centered is
Well-
less loaded.
Well, I think
But
the
equally
part
considered.
that, I think the part that Dr.
Yeah, right.
Roger's saying and not saying is compassionate and patient-centered. This is one of those really kind of fuzzy gray areas, right? Because sometimes the indication to taper is there where patients are really fearful and not aligned with the idea right now, right? And so we have to define what compassionate means in that gap right there, because tapering is, even though they're fearful, then tapering needs to. So what does compassionate care look like in the face of the patient's genuine fear of what's going to happen next as a result of that?
So let me see if, and again, Helen, I'm going to come to you, but if anybody specifically want to chime in on this compassionate, is it patient-centered that we're talking about? Is that the language or how it's
Yeah, but I don't think doing exactly what the patient wants is not always good care. I mean, and sometimes you end up pissing off the patients, and sometimes patients leave you because they don't like what you did, and maybe years later they realize you did the right thing, maybe they don't, but so I agree. I even have trouble with the word patient-centered, because I think that's come to mean a whole other thing too.
So, oh, go ahead.
Actually, I think trauma-informed might actually address what we're trying to get at, because we may know, okay, this is not safe, this is safe, but within what is safe, there might be choices and supports and ways to present that gently and supportively that's trauma-informed that can be seen as compassionate and patient-centered, in which, like, we are giving everything we can to the patient without actually giving them an option.
But sometimes what the patient wants doesn't fall into, it might not fall within that.
So here's what I'm doing. I'm going to go to Helen, then Michelle, and then to Sue.
So in the patient engagement, patient-centered, trauma-informed stuff, I think a piece could be shared decision-making. And at times, the patient doesn't always agree with what you're suggesting, but then that's where there needs to be more conversation and get to a place of acceptance, consent. It's not consensus, but acceptance, for lack of a better word.
Michelle and then Sue.
All right, so I'm going to chime in a way that, so we can have all of these things. We can say compassionate care, we can say patient-centered. If you get the order wrong of these things, it doesn't matter if it's compassionate care or patient-centered. We need to focus on how are we going to get these guidelines in an order that makes sense. If you're not having the communication around why to even do this with your patients, then why would you even start guidelines at all? It matters about the order of how you approach your patients. The language around compassionate care or patient-centered, that can be all day long. That part doesn't matter.
Right. I hear that. I appreciate that. Sue.
I was just going to piggyback on
I'm Eve.
so when you think about trauma informed, it's harm reduction. It really is a principle, and whether that's patient, if you want to say patient-centered, whatever, compassionate, harm reduction through through patient education.
I think one of the challenges here is we're really talking fundamentally about this concept of informed consent.
Yeah.
And I think there are good ways to have conversations about informed consent that are more helpful, and some that are less instructive or helpful in the communication piece with patients. And I see this a lot, especially with my palliative care patients or my ER patients, honestly, too, who really become an intersection of psycho-emotional trauma, significant organic disease, and how do you really talk about the risks and benefits of choices that are presented to them while being very respectful of patients' autonomy, but also understanding that they do not have the educational background and evidence-based background to necessarily have the understanding that we as clinicians may have that is different than what their expectation or hope or desire is. And I think that that's really the crux of where the trauma and the distrust comes from, not to speak on your behalf, but I feel that
very much so, it's something important. And maybe that's like the elephant in the room. It's this piece of informed consent that we all know that that's out there, that's a thing that's being looked at of informed consent. If you're doing this without consent and you're pushing the issue to your patients.
Let's back that up.
Hold on, let me have Michelle finish. Go ahead.
That if you're pushing your patients into a direction that they're not comfortable with, you're going to have to be able to get them to a comfortable spot with it before you can keep pushing. And so many patients are pushed and pushed and pushed, and they end up, things fail with them. They turn to dangerous things because of the failure.
Go ahead, Paul.
So the failure in informed consent was when the opioid was started and got to this astronomical dose. You know, nobody was talking about the number needed to harm with that patient, how many patients it takes to treat with this dose to get addicted. It's in the literature. Evelyn showed that if the dose is 120 milligrams and above, the number needed to harm is about 17. 1 in 17 will become addicted. In my high dose patients, 315 milligrams and above, number needed to harm, 1 in 3 become addicted. So the discussion, the informed consent should have happened before we started the opioids, not now, because some of these will be forced tapers that work.
But I think what I was getting at is that I think there's a way to do that is mindful and respectful of the patient experience in that, which includes, trust me, I've had my fair share, I'm sure everyone in this room has, of very difficult conversations with patients who did not want to be tapered down or off medications. I think the piece that, I guess, the component, I guess it kind of spills into the component aspect of this, is that whatever guidelines we put in place, there's got to be a script or an educational piece that provides the clinicians who are not as savvy or comfortable in having those conversations to the tools that they need to do this better or well, as compared to, hey, congratulations, PCP X out in location Y, good luck. Here's a set of guidelines. I think the educational piece that addresses this is super important.
So BJ and Safina.
So just to play devil's advocate with Paul, I would say that 2 wrongs don't make a right, and just because people were started on something without informed consent doesn't mean we should change things again without informing them and getting them on board. So I think informed consent is important. And I'd also say, to echo your comment, this really needs to be practical, because we talk a lot about how hard things are to implement, and what happens at an academic health center may look very different than what happens in Medford. And you know, we consider ourselves resource poor compared to Portland, but there are places on the coast that are resource poor compared to us, and they need to feel like this is doable too.
So I was gonna say 2 things. Yeah, I wanted to make sure you wrote down informed consent, because though this isn't the point in this task force, I think absolutely that should be like the mantra when we're approaching chronic pain patients and talking about whether they're opioid naive, are we going to start it? But then also, I think it's a really good way to think about the tapering conversation, because it brings in that piece I was talking about, safety. And what I meant when I said safety was sharing the why, is like the successful tapers that I've had, you know, the ones that really, you know, over time that people are able to buy in and understand, etc. It starts with talking about their safety, and that this is about safety, and this is about the harm of the medication, and we have not done that enough as a medical community. And that concept of informed consent, at least from a medical community perspective, people understand that because that's how we approach procedures and surgeries, etc. And so I think talking about these medications that are so potentially harmful and using that verbiage, I think might speak well to the community of providers.
So I have Ruben and Kim.
And part of that is you're asking physicians to do something that they haven't done and don't know how to do, and that's where scripting comes in. Like with the whole module of the Oregon Pain Management Commission, there's a lot of scripting in there, because if you tell physicians you should taper everybody down to 90, they're like, how do I do that? How do I start that conversation? And you know, let's be real. There's a wide range of skill in physicians, and a lot of it is not, like, their patient skills are often not that good. They know how to do what they know how to do. I mean, it's sad, but it's true in every profession that they're just like, there aren't good communicators.
Kim, Jim, and David.
Yeah, this probably goes under components, and it probably speaks to both Safina and Ruben right now, in that supported tapers when possible.
Say it again.
So supported tapers. So you have a interdisciplinary team who is, while we're tapering down, is that we're teaching all sorts of self-management skills to increase the patient's self-efficacy and managing both the fear of the taper as well as managing the condition in which we are tapering from, which I will argue we also have not done a good job in. We have not done a great job in the chronic pain population of making sure that they have those modalities and skills readily available to them. And this is a really great opportunity to do that. And so in some ways that offloads some of the bedside, collectively improving bedside manner and communication among them. And then it also becomes, when that's available, part of the team's effort of making sure that education is just in the forefront of the why, and we're going to help you and we're going to support you while we do this.
So we have Jim and David.
So I also think, and I don't know if it's in the principles or guidelines, but or components, but I think we need to be open to and unbiased about the diagnosis of opioid use disorder in a very broad way. So chronic persistent opioid dependency, for example, where people remain at high doses, they don't have all the classic components of addiction, and yet they're stuck in an unsafe place. You know, if we could think of buprenorphine as an appropriate tool for those folks, I think we could do a lot of benefits. So my feeling is that buprenorphine at some point is going to get woven into all this.
So I want to make sure, Jim, that I catch you open to a broad definition of substance use disorder. Is that okay? David.
So it seems to me that we're reinventing the principles of pain management, and that we just ought to say that. That the principles that apply to pain management apply here. And it has to do with integrated care, it has to deal with understanding social context, it has to do with being trauma informed, it has to be with, and I think we ought to find one and use it and not create another one. Because there's just, we're all pretty much on the same page, I think, and this proves it. But if I were opening a guideline and it had a bunch of principles that sound like this, I'd flip to the next page immediately. So, but I think there's an advantage in saying, look, this is part of the practice of pain management, and the same principles applies as articulated here, and we agree, and we're gonna move on from there. I want to add one more thing.
Yeah.
Before we go into resources, I don't understand what the chapter headings of this are.
Yeah.
Right.
So we're not going to resources. This is so I didn't forget.
Okay. So but it would be helpful, I think, before we leave, to understand what. And I've been writing my chapter headings. What are the chapter headings we're going to be talking about? Because I have no. Everybody.
David, this is the components discussion. That's exactly where we're going. I promise.
All right. Thank you.
So this is certainly not a principle, but I do think we need to pay attention to stigma here, because what I see happening is that there's this division that some things are for pain and some things are for addiction, and we use the term addict, which is not a very good term to describe people. And so I would hope that the concepts of compassionate care, informed consent would cover all people who are dependent and use non-stigmatizing language.
Okay, so I want to check on David's suggestion or question about, we can, I think this is a good list. We can also go look at some principles behind pain management. Do folks agree that just sort of cross-reference them, see where there's good? Okay, I'm seeing nodding. Anybody don't like that idea? David won't be offended if you disagree with
No, I don't care.
I don't disagree with it, but I think it's important to remember that the people who we are putting this guideline out to are not the subject matter specialists we are in this room. So to us, it's obvious. To the person reading this guideline, it may not be at all.
Right.
So I think that whatever those principles are that we agree we're going to copy and paste, that we make sure the language of that copy and paste is for someone who does not get this concept to begin with.
So part of the principle, I think that if this went to the shelves, make sure our language is really clear. And it's very clear. So we will take these, we will look at some of those principles behind pain management, and we'll bring something back to you to make sure it's reflective of this conversation. Okay, anybody else, any final thoughts on this? Because now we are going to go, the components, we're going to do two other things, right? The components are, David, what you're saying, sort of like, what are the chapter headings, right? Like, that's what we were thinking when we were thinking components, sort of like, what are the big pieces that should be included in the guideline? And then this piece was, we gave you guys, a list of resources, But we want to be sure that if you have other resources that we should be drawing upon and looking at, that we're capturing those. Y'all are a bunch of experts, and we want to be sure that we have those resources. So that's what this is about. And as I said, this is so I didn't forget to have this conversation with you.
So I think definitions would be a really important start for the guidelines.
So here's what we're going to do, just so you're getting us kicked off. Here's what I'm going to hope we can do together, and is that the headings, right? So what do we mean, the definitions? I'm hoping right now, if we have time, we can go there later, but that we don't actually talk about the substance of each of these pieces, but what are the big headlines? So that's sort of where we're going. David, do you have an amendment or chapter headings?
Yeah, I mean, I'm sort of thinking about this. I think Roger's point about that there is no evidence saying that you have to taper everybody off is sort of the start point. And what is the evidence? I mean, we're defining what the scope of this is, and it's sort of what the evidence for tapering is. It's both the fact that there are harms, the fact that there is no mandate to taper everybody off. That's sort of the definitional statement that starts this whole thing. And then I'm just going to run through my list, which is you start with that, then you say when to consider tapering, considerations before tapering.
You have to go slow enough so I can.
Well, I mean, I can give you the list because I've written them down, but I mean, it's just sort of helping people on what's the process, you know? So when to consider tapering, considerations before tapering. Is the person homeless? Do we need to refer them to care management before, because we know whatever we're going to do is going to get undermined, right? Considerations in initiating tapering. How do you start, right? What to do when the patient is failing a taper, right? What do you do when things aren't going well? And basically goals for tapering. Where are we trying to get to? When are we done? I mean, I think concrete things like that are what people are going to look for, because I've got a patient in front of me. Where am I at? What chapter do I go to? So to me, that really makes it very, very concrete for providers.
Just give me that last one.
Goals.
After what to do and
how far do you go? I mean, when are we?
What's the goal?
What's the goal?
How do you define success?
Yeah, that's even a better way to put it. How do you define success? We're done. You're at X, and you're doing great. Then God bless.
And there should be an Appendix A that's scripts.
Right.
All the scripts
Yeah.
in Appendix A.
We should also start with why. We've talked a lot about the why today.
That's the definitional statement.
So the why, that's sort of a definitional.
Right.
And that's I think that's the evidence piece.
I think the other thing that comes up all the time is we talk about risk and benefit, and they can't. Sometimes those are hard for people to assess. So being really clear on risks versus benefits, where the balance is. Because some people don't assume that we mean zero risk.
Yeah.
There's no. I mean, every treatment carries its own set of risks.
So this is a chapter about how to talk to the patient.
So what?
This is a chapter about how to talk to the patient about tapering.
Like in the scripts.
Right in the scripts.
Yeah.
This is what to say. This is a suggestion how to present it.
And difficult conversations.
So let me hear from Kim.
So, no, I was going to say the same thing. And then the other thing I was just going to say is we may want to have some kind of either script or headings or somewhere to say other resources for other things while you're tapering or somehow. I mean, I don't think we want to make a whole other document with all the other alternatives to opiates, but somewhere that we can link them to get to other medications and other resources while we're tapering. We can add on more. I'm not wording that well.
No, but that's
like
support.
that's kind of what I'm trying to do.
Supporting materials.
Supporting materials or supporting things to help you while you're going through. And that could be in some of the chapters we've already said.
No, I think it's great as a call out, because people might just flip there.
Yeah, I mean, sometimes that's where I need to go, right?
So I have, I'm going to go to Kim, Michelle, Katrina, and BJ.
Under assessment, chronic opioid therapy, one of the depression is a long-term consequence. And so I think we need to add some mental health measures into assessment. Depression screening and suicide screening should be routine parts of that. Although the evidence is not in general supporting increased rates of suicide with tapering, we're in the middle of a syndemic. We're at a 30-year high of suicides. There are case reports of that, and I'm with Katrina. Any death for any reason is problematic, so I would add to those is part of a tapering protocol.
Michelle, BJ, then Katrina.
Then what? Once you get them to the taper, then what? And also the long-term effects of what they're going to be feeling once they get to where you tapered them to. This is, your life 10 years from now, and this is what you're going to feel after the opioids are lower, or possibly if you did wean them, what then?
What to expect after tapering.
Yeah.
Both during and after. Like drawing out a map of what.
BJ.
I would say in addition to assessment and reassessment, I think a common error I see is that once a taper is started, then kind of tunnel vision and we're going come hell or high water. And I think that periodically asking yourself how this is going could really help PCPs in particular.
Katrina.
Yeah, I was just going to say, in the context of not reinventing the wheel, I had just pulled up our acute prescribing guidelines. So completely different area, but it really addresses a number of these things. So I want to be sure that whatever we do, we talk about it building on other work that's already been done. So just quickly, rationale for the guidelines, efforts to promote, say, prescribe, again, the context, approach, here it says acute pain, but this would be approach to pain in general. And then the areas are evaluating patient, assessing history of long-term use and or substance use disorder, the distinction between the two. This says check the PDMP, may or may not be as relevant for this. Patient education, amount and type, again, that could be different for this. And then patient follow-up is that reassessment, and then what do you do long-term? So I just think that might be a nice way to lump it, but I was going to start off by saying this, and then most of this has already been said in different contexts, but that was our approach, again, to the acute guidelines, was this sort of soup to nuts.
Please.
One thing that we can talk about is what's the goal of doing this, because we haven't mentioned function at all. The goal should be pain relief, or if you tell patients we're going to taper you down, it's going to make you feel better, your mood is going to be better, your function is going to be better. So rather than saying your pain is going to go up, because people associate this as painkillers, right? So if you're taking away a painkiller, the pain's going to be exacerbated. But we can, in our practice, we've seen that function actually improves, the patient's depression gets better. So incorporating that, and that's just the guideline of pain management, where you're managing your pain with other strategies, and you're actually improving function.
So you have clarity on the goal for the patient. So the patient is Paul.
Just unfortunately going back to what we talked about.
That's okay.
There are people claiming in the United States that the sky's going to fall if you taper people. I think we should be following outcomes longitudinally. Do suicides increase?
Yeah.
Look at the numbers of heroin and fentanyl overdose deaths.
Yeah.
We should be following data, not just prospectively, but over the long term, to make sure that we aren't. One of the things Roger said is he'd like to know that my data, I'm not having increased suicides. I'm not having increased. So the state, we should do that, in some ways, so that we can reassure Michelle that we're not seeing those spikes.
Good. Kim.
I don't know how to say this in the reassessment, but tapering is a dialogue, right? There has to be an element of control between the provider and the patient. And so that the rate of taper is a mutually agreed upon decision between them, which means that the pace of the taper is going to vary based on what is mutually agreed upon between the provider and the patient. I don't know how to say that, but that's part of that reassessment.
It's that shared decision-making model. They've used it for years, for 20 years for diabetes, right? Retention, same kind of idea, engaging patients, interviewing to change in behavior. And we have those tools already on the OPG website and conversations.
So tailing in on that, tapers can be too fast, just right, and too slow. I think we need to recognize that if you're there needs to be signs of when it's going too fast, but you can dwell too long in a taper and you're exposing the patient. So we just need to recognize that there's probably a sweet spot. In my practice, it was about 20 milligrams per month, not 10% per week. But looking at the 104 patients that successfully tapered, it turned out to be 20 milligrams per month. So that's a linear taper, so we're advocating for a linear decline, not exponential when you use 10% per week or something that's too fast. So hopefully this is going to come out.
Generally, I like all these ideas and concepts. I'm a little hesitant to build like either an exact pace or even so much as to say that always there has to be patient consent to taper. It's rare, it's certainly not what usually happens, but sometimes you see a patient who's like in acute danger right now, and then it kind of just needs to happen. So just the way we word that, we definitely want the patient as much in the conversation and decision making as possible, but they can't always.
So how would we capture that?
I don't know. I don't know.
So one idea is sort of this
Just say that.
ambivalence, like, because I think it's ambivalence, even though it looks like resistance, right?
Yeah.
I think it's like, I'm not sure I want to, I don't want to, and I think, even calling out, how to approach the highly ambivalent patient, or
that's good.
Highly ambivalent provider, or highly ambivalent family member. So there's something about being able to approach people in that high state of ambivalence and sort of know how to navigate that.
And I want to throw out there, if you look at the evidence on consensual tapers, it's horrible. It's about a 25% participation rate. 75% opt out. So it is really, really important. And we're being called the forced taper group. And if all tapers are consensual, 75% of tapers won't happen.
I think that's where the guidelines and CDC guidelines or BAPOD guidelines, that's what we tell our patients, that this is a national mandate, but we're doing it because of your safety. Whether you consent or not, we have to bring you to a safer dose. We're not tapering you off. And we have, different data sets, reviews, where I can tell you exactly what your risk is of dying in the next year or in the next 3 years if you stay on this dose. And that's not just based on opioid doses, it's based on your mental health issues. If you've got PTSD and you've got COPD and sleep apnea, your risk of dying is 43%. So I can do something that's unsafe. Just like when we put patients on anticoagulants, right? We're not going to put somebody who is at a risk of falling all the time on a dangerous drug. So that's where the patient conversation needs to occur.
I think we should also call out that that's very different than abandonment, because I think another label that we get is that we're the abandonment group in Oregon, right? That we're abandoning patients and leaving their dealer to help them on the corner, right? So maybe obviously not a component of the guideline, but calling out how these are different than abandonment, and that abandonment is never really indicated for patients.
I think that there's this piece here about definitions and what does tapering mean, to just be really clear about that language. Is that what you're going to?
Yeah, I was going to say, I think that this is such a viscerally evoking emotional topic, not only for clinicians, but especially for patients, and especially very vulnerable patients who already feel in many ways labeled, mistreated, abandoned. If I can, if you guys will humor me, I'd love to tell you the story about the guy who was sent to me, who literally came to our team requesting death with dignity. And he basically was taken off of his opiates by his prescriber because he had not been entirely consistent with keeping to the contract. But it allowed him to be functional, and he was literally cut off cold turkey from 120 milligrams of methadone. That did not go well. And he was sitting at home with a firearm. His 17-year-old son was the only person who lived with him at home. And my nurse practitioner in the outpatient setting had gotten a phone call from him saying, I'm sitting here with this gun, and if I cannot get my pain controlled, I don't want to live like this, and wanted to shoot himself. And we brought him into the hospital. I admitted him into the inpatient setting. I put him in the ICU. I put him on ketamine. I put him on lidocaine. I got his pain under control. And I said, tell me what's going on. And he explained all of his symptoms. And a lot of practitioners were kind of dismissing him as though it's just chronic pain. We found a C-spine, basically disc issue that was correctable, that was causing his excruciating pain. got a surgeon to actually see him, treated him, discharged him from the hospital. He's alive and well, living today off of opiates almost a year later. I hear this story happening more and more, and especially because I do palliative and I get referrals for death with dignity, I get a lot of phone calls about cases that have to do with intractable pain. We can't force people off of opiates. If we don't give them opiates, they'll find other ways to get it. We definitely need to gently guide them to a safer dose, safer regimen, multimodal analgesia. But the story that I just told you is repeating itself over and over in multiple ways across our state. So I think that we need to define what all the terms are. What is dependence? What is addiction? What is dependence? What is abandonment? Because I don't think we're all using the same lexicon. And so patients, because it's such a visceral thing, need the education piece. And I think we need to provide that as part of this whole process.
All right. Other thoughts?
Sorry.
Oh, Roger, please.
Yeah. I'd just like to make one comment. So I really have concerns about calling tapers voluntary or involuntary because I can't define that, and I can't tell you if my tapers that I do in my own practice are voluntary or involuntary. Somebody said that sometimes you have to do involuntary tapers. I mean, I would say the majority of time, my patients don't want to do tapers. I explain why I think it's important, that it's a safety issue, and I guide them through the process, and I try to be empathetic, but they don't want to taper. Is that voluntary or involuntary? I've actually asked researchers who have coined this term, how would you even define that for a research study? And nobody can do it. How do you even define that? I think we have to be really careful about, again, just these terms are very loaded. They're being used to denigrate, these kinds of efforts. And we have to be really careful about how we describe these things. And just, the story about that patient is terrible. But that's just poor clinical care. There's no tapering guideline in the world that says to stop patients cold turkey on 120 milligrams of methadone. Anyways, I think I think we have to be, the language is important, and has been, used actually quite effectively to, cast a lot of kind of negative stuff about some of these efforts.
Thank you so much, Roger. Kim.
I just want to dovetail off of what Roger said. I think it's a false dichotomy. The forced versus unforced taper. At best, they are gray, and they always have been. And even with the guidelines, they will likely to continue to be. Our patients are very fearful, and I think that the language is incredibly loaded. It is, and it creates a lot of confusion about what to do next for a group of practitioners that desperately want to know what to do next. And so the idea of this dichotomy of forced versus unforced, I think, is a false dichotomy.
And so, and obviously, again, this sort of it goes back to definitions, and it goes back to clarity of language, and that whatever we draft, and you got, I do a lot of group processes, and I often will say we are not writing this thing by group, and we actually do have to write this by a group process, right? Well, oftentimes I'll say there's no way, and we have to, because the language is really important. Y'all have said this again and again and again, and being super crisp and clear about what we're talking about is going to be very important. So is there anything else, and I'll tell you sort of what's going to happen before we have this conversation about resources. Any other thoughts or reflections on either one of these? These are going to come back to you, so I think, so with the principles, we're gonna, we'll look at these, we'll look at the principles of pain management, we'll see where there's overlap, we'll see where we can combine some of these, and again, go to try to be as clear as possible, bring those back to you, and then with these, you can't read this, but I can, and sort of think through and looking at some of the other guidelines to see if there's other things we want to capture, and again, bring that back to you and start we'll talk about some next steps in terms of what we want to do next month together to sort of keep us moving. So let me go here and then we'll go to
I've heard the word vulnerable. I don't know if it's up there, but I like to just call out that these are risky drugs and these are vulnerable people. So it's like how to approach a vulnerable patient regarding the risks of, anyway, so just.
Well, I appreciate the way you said that, sort of risky drugs and vulnerable people, and how did that, somehow you want that addressed in the guidelines, and I think that's probably pretty consistent with what other folks have said, but I really appreciate that.
I think somewhere, I don't know, maybe in the components, there should be a section that talks about organizational supports for this, because a lot of times, of times it's, obviously these are clinical guidelines, but there's so much more. Like, for example, integrated behavioral health, maybe for the initial conversation, you have a little bit of a longer visit, things like that. So
sort of
like speaking to administrators or organizational leadership within an organization. Obviously, if you're a private practice, it may or may not be relevant, but a lot of people work in organizations, and especially, I would say, when it comes to primary care, within primary care, I think we need to start talking to organizations as much as we're talking to clinicians.
That's great. So,
under definitions, going back to what Pete was saying, maybe defining what imminent harm looks like. So we're talking about just stopping opioids abruptly.
Katrina.
Yeah, well, with imminent harm, I'm just thinking one of the things is co-prescribing with naloxone. So if you have people on really high doses, this is down in the weeds that you weren't asking for. One of the things I haven't heard is around the assessment piece. We talked about assessing type of pain and severity, and how long they've been on, et cetera. Comorbid conditions, I think, is really important. I mean, you sort of allude to that. That's an important. We've been doing a review of all our patients who've died of drug overdose deaths. Most of them have multiple, either drugs on board and comorbid conditions or both. So that really speaks a lot to that. And then as part of the assessment, of course, and I think folks have alluded to this, the psychosocial and, the sort of trauma, you talked about trauma-informed care. It's hard to do that if you haven't actually assessed the level of kind of experience. So I just want to be sure that those pieces, because assessment is often, the sort of, okay, how much pain, what are your opioids, or what, but it's the problem with this chronic is that it's much, much bigger. And then assessing, obviously, we've talked about this too, but substance use disorder or behavioral health or mental health issues, as well as that's an important part, because there may be many patients who are on high doses of opiates for a long time who don't have substance use disorder as it's defined by a category, and there might be people on lower doses who do. So, but it's a different diagnosis.
Michelle,
what about bringing in patient supports, like their support system, to educate their support systems, to help them go through the taper, and that they would be able to kind of companion partner with that. And really be, mostly families end up being support systems for the doctors too.
Right, and I just like the start with that, idea of family support, the cultural aspect, and the other supports that they may have that are tribally based or culturally based.
Going along the lines of some of the things I've said before, one of the tools that I find necessary to avoid abandonment is an X waiver. And I feel like an X waiver to prescribe buprenorphine, and I feel like the providers in our system that are most successful have become X waiver, and that we have an opportunity to set the standard that an X waiver should be something in your toolkit. It's something that's very achievable for somebody in even the most resource-poor settings, and an essential tool in my kit. So I think we can
have that
aspirational with this guideline as well.
Jim, then Dana.
Yeah, I just want to tag on to what BJ was talking about. So if we have people on high dose opioids and we're tapering them down, we have any more than one patient, we're likely to come across opiate use disorder or all sorts of situations where you're prescribing a buprenorphine mean, you could theoretically prescribe buprenorphine for pain or chronic persistent, opioid emergency, but when you go through the training, you understand the drug, you understand, tools that would be useful for you to undergo this process.
Dana.
I'm gonna push back on what Laura said, and I will share this with her personally when she comes back. I didn't mean to say this when she left, but I'm building off what I think Michelle and Sue were both just speaking to about building off of the natural supports of individuals, the cultural supports, and I'm very concerned about the word vulnerable. I think we need to focus on the term around resilience and helping to build the resilience of individuals and working through the process of taper when that is what's appropriate for their safety. And so I will, again, I didn't mean to do it after Laura shared, but I just want to build off Michelle and Sue, and I really like that focus around building off the resilience and the social supports, and natural supports, and cultural supports when we talk about this.
Great. Paul.
Building off Jim and BJ, peers that have gone through a transition to buprenorphine are often a great resource for patients. So if you have a practice where you transition patients from high-dose opioids to pain for buprenorphine, some of those who vet are good peers to help people get through that terrified withdrawal.
Yeah.
Terrified withdrawal. So building peers, maybe even regionally, would be really helpful.
That goes to this patient supports concern. Okay. Here's what we're going to do. I never say this, but I'm going to say it. We're going to end early. but I see, I never say it because that curses me. No, because I think, no, we're not ending right now. Don't get up.
That would be early.
What's on? I didn't say 20 minutes early. I was going to say maybe 10 minutes early. Here's what I need from you, though. This is great. This is really good work, and I really appreciate it. So we have a team of folks who are working on this that will want to bring this back to you, do work in between the next meeting to bring you something in April. And what we, not me, but other members of the team looked at is this 2-page document that you have sort of pulled together a resource list, right? So what are some of the things in terms of the substance, right? So we've been talking about guidelines, we've been talking about some of, as David put it, sort of the chapter headings, and we need to do work on this to see what we can sort of collapse and pull together. And some of the places that we thought we could look for some substance and ideas are on these 2 pieces of paper. And so we were very deliberate that we didn't want to bring to you, and at the first meeting especially, something that says, here's here's what we think. What do you think? I think we wanted to hear from you sort of what some of the substance was and the guidelines, the principles. So now I think the team can start thinking about what are some of the ways we should start populating to move the conversation forward. So just hold on one sec. So the next question, and then I'll come to you, Ruben, are there any resources that we are absolutely missing here that you think we need to look at in order to get something ready to sort of bring it back to you? This is going to be an iterative process, right? And as I say, we're going to be doing this as a group, but it's going to be iterative in that we'll probably start pulling something together, we'll bring it back to you, we'll say, tell us what you think, you'll tell us what you think, we'll go away, we'll do some more work, we'll keep coming back. We may at some point ask, for volunteers to say, I want to get into some of this nitty gritty, and but we're going to be together for a number of months here, and so making sure that we have a good back and forth, a process that works for all of you and works for the team is going to be really important. So in a minute, I want to hear if there's anything major we're missing, but I'd like to hear from Ruben.
So when I look at all of these things, I mean, essentially all this you could apply to anything in medicine, and I think I don't know if we want to be a little more specific to opioid tapering, because I think all of this stuff, if I'm going to start someone on insulin, I want to be really clear and give the risks and benefits, and so. I mean, it's like, are we writing a guide to how to practice decent medicine?
Hopefully.
Yeah, pretty much.
Yeah, good. What's wrong with that?
Yeah, that's what.
No, I think that's a good point, and I think to each point, it should be more specific. And I was going to say this, but you started saying it for me. This group is not going to solve all the problems that you all experience every day, and patients and providers. We know that, right? And as Katrina sort of started us out and said, this is a piece of a much larger, some much larger challenges, and a lot of folks are working in a lot of different ways to make sure we're doing right by Oregonians, right? However, this is an important piece. So to your point, Ruben, I think getting specific.
There was one more part.
Oh, absolutely.
I think a lot of why some of the, I don't mean to harp on physicians, a lot of why this happens is also the way the system is set up, where you have short appointments and where you have patients who have all disparate insurances that some of them get access to these resources, some don't. So you can write the best guidelines in the world, you can train the best physicians, the best support staff, but a lot of this it becomes unrealistic, I guess. Yeah. You're asking, it's kind of like when I hear all this stuff about value-based medicine, this and that, except then you still get people telling you, well, you got to generate RVUs, and so there's a disconnect there. So all this is great, but it's all stuff we should be doing.
No, I really appreciate that. So I'm going to go to Katrina and over.
So thank you. I was going to react slightly to that. I appreciate that Safina had brought up responsibilities of the health system. That was something we included in the acute guidelines. The audience for this is not just physicians or nurse practitioners. You're doing it wrong, do it our way, right? It's a communication tool for patients. I think it's equally, and I had mentioned this at the beginning, the guideline's easy. You got to figure out how to implement it within health systems. I actually think that the target audience for this or whatever is equal parts or maybe more how you change the health, how you transform the setting so that it isn't just, oh, you've been doing it wrong, now do it this way, or you're doing it wrong, because it really, so I think the target audience is much broader than just physicians need to be following. Because I would echo, I think that part of this is that it is good care and people throw their hands up, this is a challenging patient, now what do I do? Well, actually, you just do the basics. You just assess, you evaluate, you try things out, you follow, you reassess, you do, it's good standard care, but that I think people might often not know what the tools are because they don't know how to have those conversations. So I just wanted to say this really is around tools, and that's a clinician piece, but the communication part of it is at least as important for the health systems and the kind of payers and that structure as it is to individual clinicians and individual patients.
Erin?
Yeah, because I was going to say, this is not a 15-minute visit under any circumstance.
No, right.
Even under the most experienced clinician. I'm wondering, and I'm kind of curious about how you guys have interacted in the past with the Oregon Health, what's it called?
Policy Board.
The Oregon Health Leadership Council, and whether this is something that can be presented to them in the context of the work that's being done, not just for this guideline, but several of these guidelines, because it really does require the buy-in of leadership from these systems to really support clinicians doing the right things by patients. I think part of how we got into this problem is it's a lot easier to do a 15-minute visit, give someone a prescription for Vicodin and be done.
It's cheaper. So the OHLC was represented on our previous guideline work groups. This one, we reached out to a number of people and they were saying, well, it's kind of specific to this population or whatever. So we can do that again, but absolutely. This one is a little bit more around content experts, et cetera, around a specific area related to tapering. Some of these others had broader representation from, again, OHLC, hospital systems, payers, all the different provider groups, associations, et cetera. So this is a little bit more focused, but they're absolutely aware of the work that we're doing. And we
I can add to that just a little bit. Yeah, I sit on the OHLC has an evidence-based best practice subcommittee. Yeah. I can never say that quite right. EBBP. Try that. And so I've spoken to this task force coming multiple times. It was really welcomed, one of those voices as a need out there, and will be an important resource for that group, the OHLC. They distributed it broadly to providers and participants on the OHLC in terms of seeking applicants. So supported, we will bring it back to them, updates along the way, and your finished product, but very much engaged. There's not someone here saying I am OHLC, but very strongly connected.
So Paul, and then I do want to get this question about resources, and I totally lied about finishing 10 minutes early. Go ahead, Paul.
So yeah, it is really important to get leadership involved because this involves breastfeeding this involves Preskini. And Preskini matters to all the big players. And you're going to have low Preskini scores when we start doing this.
Yeah.
So leadership
Yeah.
needs to be like the 6 building blocks. Remember, the first of the 6 building blocks is bring leadership. Yeah, Preskini is patient satisfaction. And
Yeah.
we worship it in
Yeah.
Providence and at Salem Health and at Kaiser.
And OHSU.
Yeah.
And everywhere.
Yeah, everywhere. Okay, any resources that you all know about that we have not captured here? Or did we?
I can look at some of our guidelines.
Oh, please.
Because
Great.
VA has this program called academic detailing, which started in 2015. There's a whole lot of pharmacists who've been involved in this process, and they've created a lot of guidelines for us. So I'm going to see if there is any future guidelines.
That'd be great. And so please do send them to Lisa. So if you have anything,
Well,
please.
and I have the full VA ones
Yeah,
on here, and then just
Yeah, the
before you guys
copy.
ask, and we'll take as many.
Yeah.
I also asked CMS, and I asked all 50 states to send me what they may or may not have. So just so you know, I'm going to add the state of Oklahoma has a whole body of work, including tapering. I don't know if you're familiar with Oklahoma's work, but they sent it on over.
Well, they also
So,
have
hold on, so let me hear.
information for rural providers.
Yeah.
too.
So,
Kim, did you have something else?
Well, I was just remembering, because I might be confused, but I can send what OHSU has,
That'd be great.
that we're in process of, and then I can send, I think we're referencing Hopkins' work on some of our opioid work. So
Yeah, and I don't
can
have
get
Hopkins.
I can get Hopkins, they have a
Great.
pretty good
That's
job.
good. BJ?
I think it's important to include the letter from the HERC, not as a piece of evidence, but as some of the common concerns that are brought up that we'll need to address with the guideline.
Good.
So can I just say publicly, BJ, so in case people listening don't know what you're referring to, there was public input provided to the HERC on the coverage consideration underway that they'll be discussing at Thursday, and it was referenced several times. Sean Mackey was one of the people that put forth. So yes, thank you. I just wanted to clarify in
What
case
that
people are
was.
listening, so they're wondering what that is. Yeah, we can certainly bring that forward.
Please,
I
Mark.
just wanted to add one thing about the guidelines, and just in my experience when we looked at the back pain guidelines,
Yeah.
in Southern Oregon, we as the CCO's kind of partner, so we have 4, ultimately 6 different CCOs. We created kind of a toolkit, talked about tapering strategies, talked about universal tapering form, and it had how to have conversations, it had
Great.
resources, what kinds of alternative therapies were covered by the people who were on the different CCO plans. And the uptake and the utilization by providers was abysmal. It may be 5%. So that would be one thing just to keep in mind.
Absolutely.
Guidelines are great, but if nobody's
Get
going
it
to
up to, yeah.
we got to make sure
That's
it's
great.
something that's addressed.
So I was going to say, looking at the American Pain Society guidelines, if we haven't already, should be included. And then I would also look at NCAM. NCAM has a lot of information out of NIH about alternative pain management modalities, acupuncture being one that I'm intimately involved with. But really, what is the evidence to support some of these other modalities? Because I am staunchly evidence-based medicine, and there's a fair amount of voodoo and witchcraft out there, and our patients are going to Dr. Google to find that.
Yeah.
And so I think providing evidence-based alternative resources that are actually backed by NIH and CAM, Oregon being the cannabis state that it is, the number of requests I get for cannabis letters is high. So if there's any resources specifically on cannabis for chronic pain and how to use that as an adjunct for tapering, if any of that's out there, that's what our patients are looking at.
Right. All right, so anything else that you have, please do send to Lisa. This is really helpful. A couple of just final remarks. First of all, next meeting is April 12th.
Yes, and we just are realizing you don't have an appointment for that. So
It was sent out as April
Yes.
20th.
now it was the 19th.
It was the
Okay.
19th.
Why don't you go ahead and take that, Dana?
yeah, no, we put it out the first time we sent out the materials, and within a couple days updated it. Sorry for that. I tried to highlight that in my email, and I so apologize. I also realize that we don't have it sent to you as an appointment yet, and we will do that. So I apologize for anybody who's
It has
that
to be.
changes. It's not for enough people.
So we're gonna.
You did?
Some people got it.
Yes, exactly. I have. You're appointed.
Good.
April
I'm glad.
12th. You don't have.
Okay.
Okay. So
Sorry.
we're gonna.
Check, I don't.
Katrina does not have.
Okay. Hold
Maybe
on.
it's just Katrina.
So we're gonna send it again. Hold on a sec, folks. We're
I have
gonna.
it on April 12th.
Yeah.
Great.
So we're gonna set. We'll try to make sure everybody has. Sounds like most of you have
Bye,
it.
Katrina.
Here's I want to make a plea, and is this has been a really, really good conversation. One of the reasons this has been a really, really good conversation is because y'all are here in person. And I understand, especially, I mean, there's a number of you who are coming from far away, we would love to have you here in person. We understand not all of you can be, but I really want to make a push. And I know Central Oregon, Southern Oregon. I'm looking at a lot of different people. And we will do our best. I know some people have to participate by phone. We will do our best to try to make that happen. And so if there's a certain, for future meetings, we have April set, but May, if you say, well, if you can make it at 2 o'clock, I can get up here, whatever it is, we will try to accommodate those of you who are coming from far, because we really want everybody here as much as possible. Any last, Dana, Katrina, Lisa, any last sort of wrap up reflections, thoughts before everybody goes?
I just say thank you for your commitment to this work and for the dialogue today. I think it was really rich and is the right starting point for the work. So thank you, everybody.
Yeah, I would agree. Thank you very much for engagement. Like I say, this is the third or fourth set of guidelines that I've been involved with, and everybody seems to have a lot of energy, so we really appreciate it. It's really important work. So
thanks everybody so much, and I'm giving you 3 minutes.
Yes.
So the institutional thing is what?
Good.
Yeah, and it's coming. You're actually.
Bye.
Thank you.
We're coming and everything. It was very ridiculous. Oh my and then we said we're going to meet
When was the last I was in China.
Connection to make sure they're
Okay.
Thank you.
I'm waiting for my letter. So that's really Which that one exception I don't think so. Or maybe my letter's in the mail and that's why I'm not. No. Totally separate. I'll ask Drew Simpson. Okay. Drew Simpson for the PDMP subcommittee. So no, Helen, you have not PDMP and Helen. Okay. I'll check. But no. What? And you're doing well and your little ones are
Well, we're almost there.
Yeah, that was good. That was like
You'll get there tomorrow.
Consensus. That was always in the details.
I feel it's interesting. The standard. I feel like this is so